Good evening, all of you. I welcome all of you. Basically, this initiative which me and Pauras we thought of about you know giving a clinical touch to a second year subjects, which I had not done prior, but I was thinking ki it is very very important when you are reading second year subjects, especially your pharmacology, patho and micro. It is very very important that you should have a simultaneous exposure of the same subject with a clinical touch. So that is something which is very, very important to understand the subject better and to have more and more interest in that subject. When I was reading my pharmacology, maybe some 10 years or more than 10 years back, it was a very, very difficult subject for me, frankly speaking, and I never enjoyed it. This is the first time that we are doing something like this, and I did not want only me to teach the clinico-pharmacological aspect. So that is why the concept came where a second year student who is not yet started learning pharmacology properly, that student should also be a part of this webinar, and a student who is already cleared pharmacology, that student should be a part of this program. So perspective or from everyone, we will see how it goes in this today's clinical pharmacological meet. So again, I welcome all of you, and I think for us we are good to go. We have a good number. People will start joining. So today we are presenting a clinical pharmacological meet on cardiovascular system, and as I said that this is the first time that we are doing it, so it is not very much in detail. So today we are going to just touch up on the four very important topics in cardiovascular pharmacology and cardiovascular medicine, I will say. One first presentation will be by Urmica Agrawal on presentation of a case of acute coronary syndrome. After that, there is going to be a presentation by Archit Shipurkar on hypertension, especially refractory hypertension. A third presentation is going to be by Aditya Nair on heart failure case, and a fourth presentation is by Aditi Gaikwad on a case of a arrhythmia. All right, and then first 10 minutes, the second year student will present the case. Then Forrest will discuss about pharmacological aspects of whatever drugs are used for that particular patient, and then what are the other options which we can use. And after that, I will tell as a clinician, as a physician, what other things are important or give my insight on that particular case. Okay, so 30 minutes for each case and 2 hours to go, so it's 607, and we should be able to finish by 607. Questions are something which we can take at the end of each session for 2 to 3 minutes. All right. So, Urmika, you can start presenting. Urmika,
Hello.
put your video mode on. That will be better if possible.
I'm sorry, ma'am.
Can you put your
Hello.
video mode? Can you put your video mode on?
I'm sorry, ma'am. I'm traveling, so that won't be possible.
No problem. Fine. Start presenting.
Yes. Okay. So, hello and good evening, everyone. Today, along with our senior Pauras and Shraddha ma'am, I've put together a presentation on acute coronary syndrome, which most of us commonly known as myocardial infarction. Okay. So today I'll be presenting a case, which is a very typical presentation. So I'll start first with the case history. A 45-year-old female, resident of Chembur, mother of two and a housewife, was rushed to the EMS at 3 a.m. with complaints of acute onset of chest pain since 2 hours. The pain was majorly over the left precordium, squeezing in character, as if a heavy object had been placed on her chest. It radiated to the left upper limb along the ulnar border and to the lower jaw. This is very consistent with the dermatomes related to the heart. The patient also complained of difficulty in breathing and perspiration, which is called diaphoresis if profuse sweating during myocardial infarction is called diaphoresis, and this perspiration started ever since the pain intensified. Moving on to the personal and family history, the patient had a history of hypertension and diabetes mellitus type 2 for from about 10 years. No past hospitalizations for any cardiac episodes. However, the patient has complained of chest pains on exertion. No surgeries, two normal deliveries. Occasional but no severe complaints of acidity after heavy eating. Acidity becomes relevant because sometimes myocardial infarction is confused with extreme acidity. Patient follows mixed diet, is has low physical activity and no history of alcoholism or smoking addiction. She has normal sleep patterns, normal bowel patterns, and has been menopausal since a year. Since she's been menopausal for a year, that increases her risk for uh, for blockages. However, the patient has had hypertension for 30 years, but no previous cardiac episodes. Other family history was found to be insignificant. So on general exam, it was found that the patient has normal build and has grade 1 obesity. The BMI was found to be 31.2 kg per meter square. No pallor icterus, cyanosis, clubbing, lymph node abnormalities, pedal or other edema was observed. The JVP was not elevated and cardiac failure is unlikely. The pulse was found to be 85 beats per minute and was normal in character. The PP was 140 over 90 millimeters of mercury. Oxygen saturation was found low. It was found to be 92% in normal air, and respiratory rate was 25 beats per minute, which is slightly high. So due to the oxygen saturation being low, she is later on started on oxygen. On systemic examination, it was found that the third heart uh, sounded like a gallop. So, in case of myocardial infarction on the LV apex, the S3 sounds are heard clearly. On RS exam, crepitations were heard on auscultation, which is indicative of slight pulmonary edema. Investigations were done, and the ECG findings were as follows. In lead 1, AVL, V1 to V6, ST elevations were found, and this is directly indicative of STEMI, which is ST elevation MI. T wave inversion was found, and reciprocal ST depression in lead 2, 3, and AVF. Troponin card test was found to be positive. CKMB was elevated. A bedside 2D echo was done, in which it was found that there is a there is an anterolateral wall hypokinesia. So there is a motion abnormality. Random blood sugar was found to be 300 milligrams per deciliter, and lipid profile had the results of the triglycerides being 250 milligrams per deciliter, LDL 150 grams per deciliter, and HDL was low as 30 milligrams per deciliter. These findings are consistent with the patient being obese and the patient having low physical activity. So the diagnosis was found to be was given as anterolateral STEMI with pulmonary. The treatments that were started for the patient, as soon as the patient comes in, the start dose is given to the patient are DAPT. So those are antiplatelet therapy with aspirin 300 milligrams, clopidogrel 300 milligrams, rosuvastatin 40 milligrams, and she was started on oxygen. She was started on oxygen due to her pulmonary edema and low oxygen saturation. The pain was relieved with for the pain, sublingual nitrate was given and 0.5 milligrams 0.5 milligram tablets, 3 doses at 5 minutes interval. However, the pain did not subside, and so injection tramadol was given along with injection MZ because tramadol is highly emetic. Now, thrombolysis was done with streptokinase, 1.5 million units in 100 ml saline over 1 hour, and cardiac monitoring was constantly done. The crisis was averted, and afterwards, the patient was admitted for about 5 days, over which the medications given were aspirin, 75 milligrams, plus clopidogrel, 75 milligrams, which is again DAPT, Rosuvastatin 20 milligrams at OD. A blocker in the form of ACE inhibitor was given. This was tablet enalapril 5 milligrams OD. Beta blocker N nebivolol 5 milligrams OD. And injection torsemide, which was a diuretic. The patient was given heparin 60 units twice a day, and a tablet alprazolam, which was anxiolytic. For the high sugar levels, the patient was given SGLT2 inhibitor, T-dapagliflozin, and insulin and regular along with NPH insulin. Syrup Dufalac was also administered, which syrup Dufalac was also given so that the patient does not exert themselves while trying to pass stool, and it is a stool softener. A cardiology consult was done, and angiography was done, in which LAD block was found. It was about 90% blocked. And finally, PTCA and stenting was advised. At discharge on the fifth day, the patient was discharged with the following medication: DAPT, aspirin and clopidogrel, rosuvastatin, T-enalapril, nebivolol, and again for the sugar, dapagliflozin, and injection mixed which is insulin and 30-70 ratio. Diabetic diet and exercise were advised along with cardiac physiotherapy. Now I'll hand over to Pauras to explain to us the pharmacological implications.
Very well presented, Urmica. It is very, very difficult to pronounce the names also when you are just entered second year after giving a first year exam. And very good, very good, very good. Yes, Forrest, you can go ahead.
Yes, ma'am. Thank you so much, Urmika, for the wonderful presentation. I'm sharing my screen just a minute. Is this PPT visible?
Yes, yes, Forrest.
Yeah. So, hello everyone. My name is Pauras Mhatre. I'm pronouncer him, and I am presently a third minor MBBS student in Seth GSMC Medical College and KEM Hospital. So, today, after every case, in short, I will be giving you an overview of the cardiovascular pharmacology related to that case. However, before beginning, I would like to say that, like eh, covering the whole cardiovascular pharmacology in such a short time is little difficult. So what I'll be doing is I'll just run wherever I need to. I feel like focusing. I'll focus wherever the practical implications or implications for like exam purposes. But otherwise, I'll just go through quickly, and I'll try my best to cover as much as possible. So with this background, we'll start. So we discussed a case of acute coronary syndrome, right? Wherein it was a case of myocardial infarction. So the related cardiovascular pharmacology will be management of myocardial infarction, and we could also correlate or we could also learn drugs used in angina as well. So the types of acute coronary syndrome are unstable angina, ST elevation myocardial infarction, and non ST elevation myocardial infarction. So angina pectoris per se does not as whole come under ACS. Angina could be stable angina, unstable angina, Prince metal angina, of which unstable is a type of ACS. But however, we'll just quickly go through anti-anginal drugs as well. So first, talking about the pathophysiology of angina, we all very well know that it is due to imbalance in the oxygen supply and the oxygen demand by the myocardium, wherein there is a decrease in oxygen supply due to reasons like coronary atherosclerosis, vasospasm, thrombosis, etc. Whereas increase in demand due to increase in the heart rate, hypertrophy, increased ventricular contractility, increased ventricular wall tension, etc. So, how do we manage it, or how do we treat it? So, as shown in the slide, we have various class of drugs available for it, for which we have nitrates, beta blockers, calcium channel blockers, potassium channel openers, and other anti-anginal drugs. So, in this, like after the with relation to this case, I'll just discuss nitrates and calcium channel blockers. Beta blockers I'll discuss later during hypertension, and potassium channel opener and anti-anginal drugs. I think it could be done like by yourself. So first, talking about nitrates. So how like what are nitrates? They are basically prodrugs which release nitric oxide in the body, and hence they are vasodilators, predominantly venodilators, but also cause arteriolar dilatation. Hence, reduce both preload and afterload. So nitrates, they're denitrated in the smooth muscle cell. They release nitric oxide and stimulate the guanyl cyclase. Then increased cyclic GMP is formed, which causes dephosphorylation of MLCK, decrease in calcium concentration in cytosol, and thus relaxation of the vascular smooth muscles. So, how does this help? So, the venodilation helps in the peripheral pooling of the blood, which causes decreased venous return to the heart. I hope you're able to correlate to your first year physiology. So, decreased venous return will cause decreased preload, which will cause decrease in the left and right end diastolic ventricular volume, which will cause decreased cardiac work and decreased oxygen requirement of myocardium. Arteriolar dilatation will decrease peripheral vascular resistance and decrease afterload. And dilatation of large coronary vessels and collateral vessels will cause increased blood flow to the ischemic area due to redistribution of coronary blood flow, which will in turn cause increased oxygen delivery to the ischemic area. So hence the anginal pain will be relieved. So then, talking about adverse effects. Uh, First, let us talk about indications or therapeutic uses of nitrates. So they're very well used in angina, like what we are discussing. Means they're used in acute attack of angina, wherein nitroglycerin is the drug of choice, and also used for the prophylaxis of angina. They're also used in premenstrual angina, unstable angina. But however, unstable angina requires multi-drug treatment. In myocardial infarction, it's used. Congestive heart failure, it's used. Hypertensive emergency, biliary colic, and cyanide poisoning. Uh, okay, so after that, we'll talk about the adverse effects. So, like naturally, if you just uh, like correlate or extend or extrapolate the mechanism of action, you could guess that it would cause postural hypotension, headache, tachycardia, palpitation, weakness, and flushing. However, there is a problem when you use nitrates. That nitrates also like tolerance to nitrates occurs on prolonged use of nitrates. It is due to decreased nitric oxide generation, depletion of sulfhydryl radicals in the cell, or generation of free radicals. So, it is very important clinically that we should give a nitrate free interval, that is 8 to 12 hours each day, wherein you don't administer, or you ask the patient not to take the nitrate. This is very clinically important uh, in my opinion. Then moving on to calcium channel blockers. So calcium channel blockers can be classified as dihydropyridines, in which you have all the dipins like nifedipine, amlodipine, clinidipine, nicardipine, and so on. And other than that, we have verapamil and diltiazem as well. So, what is the mechanism of action? Again, it will be great that you correlate to your cardiac physiology. So, if you remember, uh, there are five subtypes of voltage sensitive calcium channels. There's L, N, P, T, and R. So, L type is predominantly present in cardiac and smooth muscle cells. So, what do these calcium channel blockers do? They block voltage sensitive L type calcium channels by binding to alpha 1 subunit. They prevent the entry of calcium into the cell, and naturally, like very logically, if there's no entry of calcium into the cell, there will be no excitation contraction coupling, because it's the main ion which is involved in EC coupling in the heart and vascular smooth muscle. So, what will this do? It will relax the vascular smooth muscle and hence decrease the peripheral vascular resistance, and hence decrease afterload and decrease oxygen consumption of myocardium, as well as if you relax the vascular or the coronary like vascular smooth muscle, so in coronary vessels there will be coronary vasodilation. So again, increased oxygen supply, so relieved anginal pain. Okay, so where are calcium channel blockers used? Again, exertional angina, variant angina, unstable angina. They're also used in hypertension, cardiomyopathy, migraine, Raynaud's phenomenon. There are many uses, but I think angina, hypertension, uh, hypertrophic cardiomyopathy, and supraventricular arrhythmia are the important ones. So that was it for this part. We'll discuss the other drugs in detail and in more understanding. Like PPT is better in the further parts. I'm done with the like. I hand over to Shraddha ma'am
Okay,
to
okay. Okay,
discuss it
thank you for a
clinically.
good revision of calcium channel blockers and wonderful presentation. So, all of you, whenever a patient of acute onset of chest pain, all of you put your video modes on. Come on. So, whenever a patient of acute onset of chest pain comes to you in an emergency, then you have a very few differential diagnosis. Okay, Porus, can you mute yourself? So, you have very few differential diagnosis in your mind. So, basically, when I'm sitting in an emergency room and I'm facing at 3 o'clock, the patient of Urmica has come at 3 o'clock in the morning. She's a middle-aged female with known diabetes, known hypertensive. She's postmenopausal. So she has multiple risk factors. And somebody who is coming at 3 o'clock, Mutuza, you have to be really alert even when you are sleeping at 3 o'clock in the night in the emergency after the 24 hours of duty. Okay. So the differential diagnosis which I'm going to give here is none other than the acute coronary syndrome I would like to rule out. And as he has already said, what are the acute coronary syndromes? The three things which are there. One is the unstable angina, another is the STEMI, and another is NSTEMI. So whenever you say that there is a STEMI and there is unstable angina, basically in unstable angina, there is ischemia, but there is no infarction. Whereas whenever you say STEMI or NSTEMI, when the I comes, that is something which is an infarct, that is the death of the tissue or death of the myocyte. That is the difference which you have to understand. Okay, and hence when what investigations, another differential diagnosis which you can give at this point is of course the GRD related acid peptic disease can be there. After that, samyak it can be some cardiac tamponade can be there, where there is a sudden accumulation of the fluid in the two layers of the pericardium. Either it can be rupture of the free wall of the left ventricle, or any traumatic pathology can come up, correct? Or else it can be a aortic dissection. That is something which is from cardiology point of view, which can come to us with acute onset of breathlessness and pain. Fine. So ACS, aortic dissection, cardiac tamponade, तीन चीजें हो गई. From GI point of view, we will think of a GRD possible still. And from respiratory point of view, acute onset of chest pain, pneumothorax is something which is sudden accumulation of air between the two layers of the pleura. It can be traumatic, it can be non-traumatic, or else that can come as a acute onset of chest pain. And very important differential diagnosis from pulmonary vascular point of view is pulmonary embolism. Acute onset of thrombus formation in pulmonary artery, it is extremely painful, and acute onset of breathlessness patient is going to have. Then again, a rupture of the esophagus, Borhav syndrome can present like acute onset of retrosternal type of a chest pain. So these are few differential diagnoses which should come into your mind when you are sitting in that emergency room. So what is the first investigation you are going to do? So first investigation you are going to do is you are going to tell the patient to get a ECG. But before telling the patient to get a ECG, always look up in your patient how vitally stable or unstable your patient is. Okay. So a quick check on the pulse, a BP, you put your stethoscope on the respiratory system or on the lungs and look if there are any crepitations of the pulmonary edema which your patient is having. Okay. And then there are some subtle clues which you can get, like as the patient was having left ventricular failure, there were crepitations which were present because of pulmonary edema. If it is aortic dissection, then I will get inequality of pulse and blood pressure, because it may dissect only one territory and other territory is spared, and that is why you will get inequality of pulse and blood pressure. That will be one clue to your patient who is having severe pain radiating to the back. If it is pneumothorax, there will be absent air entry on one side. So there are some clues, but after that, what you're going to do here is, Shubha, you are going to ask for an ECG. What do you look up in the ECG to diagnose it as an acute coronary syndrome? So basically, when you look at the ECG, there is a P wave, there is QRS complex, and there is a T wave. And between the QRS complex and the T, there is something called as a ST segment. So to diagnose acute coronary syndrome, we generally have a look at the ST segment and the T wave abnormalities. Okay, so whether there is ST segment elongation or ST segment elevation is there, or if there is ST segment depression is there, there are criteria for that. So to call it as a STEMI, you have to have a ST segment elevation of at least 2 millimeters in two contiguous lead, in a precordial lead, and at least 1 millimeter in your limb lead. So there is criteria, and then only you will say that that patient is having STEMI. Or if there is ST segment depression, which is that, then there is NSTEMI. And there are T wave abnormalities in the form of tall hyperacute T waves can be there, T wave flattening can be there, T wave inversion can be there. So these are few things which you will look up in your ECGs. So how do you differentiate between your STEMI and NSTEMI? We understood. STEMI will have ST segment elevation, NSTEMI will have ST segment depression. But how are you going to differentiate between your STEMI and STEMI and unstable angina is by the troponin levels, by the cardiac enzymes. And as I said that your unstable angina is an angina. It is not ischemia, it is not a death of the myocyte, and that is why these enzymes, CYP-KMB or troponin, are going to be normal in your angina, whereas in STEMI and unSTEMI, they are going to be elevated. So in our patient, it was a positive troponin CART test, which is a bedside test. You just have to put how the urine pregnancy test is there. So you just have to put a drops of blood in that well and wait for 15 minutes. And if you get 2 lines, then that is something which is a positive test. All right. So basically, she had a beautiful ST segment elevation in leads representing the anterior and lateral wall of heart. That is 1, AVL, V1, V2, V3, V4, V5, V6. So that is extensive anterolateral MI. She has a troponin test which was positive, and on that basis, Murtuza, we diagnosed that patient as a ST segment elevation myocardial infarction. Now, when you come to the treatment of STEMI, then you have to thrombolize, because it is a fibrin-based clot which is there in the coronaries, and that is why you will use something called as a thrombolysis agent. So there are 2 modalities of management. One is called as a PCI, that is primary percutaneous coronary intervention, and second is something which is your chemical thrombolysis. So at any point of time, your PCI is something which will be done by a cardiologist in a cath lab. He will do a CAG, there will be a removal of the clot, and a PTCA, that is percutaneous transluminal coronary angioplasty, and stenting will be done. So at any point of time, your primary PCI is something which is always better than your thrombolysis. Always. But a cardiologist has to be there 24 hours, a cath lab has to be there, and patient should afford that procedure and the stent placement, which is going to cost like 50-60K if you are putting one stent. Are you understanding? And that is why most of the time in an Indian scenario, what we do is we thrombolize the patient. So what are the thrombolysis agent that you all are going to see? What prescription Urmica has shown today, that is one of the most important prescription for pharmacology and even for final years over here. So the 3 important thrombolysis agent which we use is streptokinase, which is cheaper. It costs around 2,000 or some. Second is your tenecteplase, which are expensive because they are fibrin specific, and they will lyse the fibrin only which is present in the clot in the coronaries and do not touch other fibrin. Are you understanding? That is why their complication will be less elsewhere in the body. So tenecteplase is something which is given as a 0.5 milligram per kg body weight. Even if you don't remember the dosages, it is okay. And then you have retiplase. So remember one thing, R for retiplase, R for repeat the dose, Murtuza. So how you give it? You give a shot of a retiplase 10 units, and after 30 minutes again you give a second shot of retiplase. So R for retiplase, R for repeat the dose. So you can use either of this. So if you see, look at the cost of the tenecteplase, it costs around 30,000, retiplase costs around 30,000, whereas streptococcus is costing only 2,000. So why that much difference is there? Because the less two are fibrin specific, that is why. So one is thrombolysis. And then once you thrombolize, before thrombolysis, she had given a stat doses. So what is a stat doses? Basically is when a patient of ACS comes to us, we give a very high dose of antiplatelet, which is 300 milligram of aspirin, 300 milligram of clopidogrel, 80 milligram of atorvastatin. Those are called as a stat doses. And such a high dose of statin is given to stabilize that inflamed rupture plaque, okay, in the coronaries. That is the reason. And then pain management, sublingual nitrate we tried, it did not work. Tramadol we given, you can give pethidine also, and we used to use morphine as well. But then there are some plus or minus things about the morphine, and that is why the use is something which is not much. Now, after that, in your prescription of ACS, you have to do a RAS blockage, okay? Because RAS, renin-angiotensin aldosterone system, and LV remodeling is something which is going to further cause a ischemic cardiomyopathy. So RAS blockage is something which is important. Now, one thing which I will tell you is ACE inhibitors and ARBs are RAS blockage. But one rule is either give ACE inhibitor or give ARB or give ARNI. Never give a combination of ACE or ARB. Never do that. Never do that. Okay. So RAS blockage is something in the form of enalapril ACE inhibitor we give to the patient. And beta blockers, why you need a beta blocker in ACS unless there are contraindications like bradyarrhythmias, because beta blocker is going to reduce the rate. And if patient is having bradycardia, you do not want to reduce the rate further and cause the arrest to the patient, correct? And if patient is having cardiac failure in the form of pulmonary edema, you will not give beta blocker, because beta blocker is having a reduction in the inotropic force of the heart. So already the heart is not pumping well, and that is why, because of the back pressure and congestion, the fluid is getting accumulated in the alveoli. If you give a beta blocker and if you reduce the pumping further, there is going to be a worsening of the pulmonary edema for that particular patient. So make sure you auscultate over the chest for the crepitations before giving a beta blocker to a patient. So beta blocker you give because you do not want much of a tachycardia in your ACS patient. Always remember, ACS patient, we try to bring down the heart rate to 60 and 70, because more the tachycardia, reduction in the diastole, reduction in the coronary perfusion, that is what is going to happen, and more ischemia. It's a vicious cycle basically. Okay, so another thing is beta blocker. After that, what we have given is statin. You have to continue for dyslipidemia. And then what we have given is an anticoagulation. So look at prescription. There is a low molecular weight heparin which is given for 5 days. The dose is 1 unit per kg body weight, 12 hourly for 5 days. AHA says that you have to give it for 48 hours minimum, and you can maximum give it to 8 days. Generally in KEM, we give it for 5 days. Why it is given? Because you have invested so much money in thrombolizing one clot which was present in the coronary with which patient came with. But then that coagulative environment, because of that ruptured acromatous plaque, is still there. And that is why you do not want another clot to get formed and another streptokinase or another retiplase or tenecteplase. Are you understanding that? And that is why you are giving an anticoagulation and antiplatelet environment for that patient when this coagulant environment is present. So that was about DAPT, the pain management, the statin, the RAS blockage, beta blocker, thrombolysis. And you have to give some anxiolytic to a patient because, yes, you will be scared, correct? And you have to give some stool softener to the patient, as Urmica said that, because the patient should not strain for the stool. Sympathetic stimulation nahi hona chahiye bahut zyada isliye. Now, as our patient is diabetic as well, so that is why she said that insulin, her sugars was 300 plus. So one more rule for all of you. Any emergency in your medicine, like stroke, like infection, like MI, like pregnancy, sugar control has to be done with insulin and no oral anti-diabetic drug. Always remember this. Always remember this. And that is why we started her on insulin. That was a combination of regular and intermediate acting NPH insulin. And there is one more drug which we added was SGLT2 inhibitor. And that was what? So that SGLT2 inhibitor was dapagliflozin. What is the reason to add SGLT2 inhibitor in this patient? Is not a sugar control, definitely not. Whenever whenever your diabetic patient is having a ASCVD, high ASCVD risk, ASCVD means atherosclerotic cardiovascular disease risk. Like here, the patient is having ACS. Always SGLT2 inhibitor will go higher up in the list after metformin. Why? Because it is sodium glucose transporter, correct? And it is allowing that glucose to go out of the nephron, but at the same time, it is allowing the sodium to go out of the nephron. That is called as a natriuresis, which is helping in reduction in the intravascular volume. Plus, there are SGLT2 receptors which are present in the cardia, which are helpful for the high ASCVD risk. So, summarizing just 1 minute more. So, patient came to us with pain. We did the ECG, we did a cardiac troponin test, we diagnosed with STEMI, we gave the stat doses of clopidogrel, atorvastatin, we did thrombolysis. There are contraindications for thrombolysis also, which we will discuss some other times. After that, what we did is we did pain management with sublingual nitrate. नहीं कम हुआ तो हमने ट्रामेडोल दे दिया, ट्रामेडोल के साथ एमसेट दे दिया. DAPT we continued, streptokinase से thrombolysis किया with cardiac monitoring. There is something called as a reperfusion arrhythmias, all the final year over here, which is especially accelerated idioventricular rhythm, which is a good sign that arrhythmia is. And then we gave DAPT to a patient, statin to a patient, RAS blockage, either ACE or ARB or ARNI. And what we have given is beta blocker unless there was a contraindication. Then what we gave to the patient was anticoagulation and a good sugar control and SGLT2 added because of high ASCVD risk. So after this, what are we going to do? Because we will have to do a CAG, and according to the blockages, which was in the LAD for this patient, we will have to do a PTC and stenting. So when you do a PTC and stenting, which is percutaneous transluminal coronary angioplasty, and what we do is you put a stent. So either you can put a bare metal stent to a patient, or there are DES, which are a drug-eluting stents to a patient. Okay, so you have sirolimus and multiple drugs which are incorporated into that stent, which prevent the stent thrombosis and fibrosis. And a good cardiac physiotherapy is extremely important. Okay, so that is what is the clinical aspect for the ACS. And last thing is, if your patient has a pain, but if you do not get the ECG findings in the ECG suggestive of ACS, never send back your patient home. There is something called as a dynamic ECG monitoring. Keep doing ECGs every 30 minutes. It is okay. अगर नहीं है ST elevation, T wave inversion, एस वाले ईसीजी में आधे घंटे में आ जाएगा. मेक श्योर दैट योर पेशेंट इज देयर इन फ्रंट ऑफ योर आईज, बिकॉज वी हैव लॉस्ट अ यंग मैन who had come with a left-sided shoulder pain, acute onset, not a chest pain, left-sided shoulder pain, went to ortho, diclofenac was given, muscle relaxant was given, patient was sent back home. Again, patient came back because pain was not relieved, and that is how we lost the patient. So if you have a high suspicion clinically, but ECG is not helping you out, the troponin is not helping you out, it may occur. Just do the hemodynamic, or sorry, the ECG dynamic monitoring. That's it from me for ACS. This is nothing. This is hardly 10% of ACS that I can teach you people, but I just have time and I have already overcrossed the time. So next presentation is by Archit Shipurkar on hypertension. Archit, welcome. You're on mute, Archit. Yes, start sharing your PPT. Archit, do you have any signal problem? Can Aditya Nair go ahead with a heart failure?
Start.
Yes, start.
I'm a second MBBS and KEM Hospital.
Archit, you're there. We can't hear you properly. Boris, I think he has left, is it? Because of signal issues?
Yes, ma'am.
I think Aditya can go ahead. Aditya, don't waste time for all of us. Let's start. Aditya can go ahead with
Archit
first
joined
segment.
back. Archit joined back. Ma'am, ma'am, Archit joined back. We can take
Okay,
Archit's
fine, fine,
part.
fine, fine. Ajit, start presenting. Not an issue.
And I guess it's better to go in the decided order because I made the PPT in the decided order, so like things are not repeated and stuff.
Hello, am I audible?
Yes, Archit. Yes.
Yeah. So, a 46-year-old female homemaker and a known case of hypertension since 6 years
Archit, can you make it
came
a
for consult.
PowerPoint presentation? It is something which is showing all the slides together. Is it possible for the slideshow? For the
Yeah,
slide.
Ju-
yeah.
Just
Yeah.
drag.
So,
Yeah.
she was on following medications: nicardipine 30 mg OD, metoprolol succinate 75 mg, telmisartan 40 mg, and chlorthalidone 12.5 mg. She further underwent renal denervation as a treatment against refractory hypertension, a very important clinical finding. In the history of past illness, she had an history of episode of bleeding from mouth. She was admitted for hypertension emergency, which included bleeding from mouth, hypertension and encephalopathy, transient ischemic attack. She had an history of palpitations with associated headache, but no sweating. She had a family history of hypertension, but late in onset, which is an indicative of primary hypertension in her case. She had no history of pregnancy-induced hypertension. Okay.
It's okay. You read. Huh.
On general examination, her weight was found to be 84.9 kg. Her right upper limb pressure was 180 120 millimeter Hg. Her left upper limb pressure was 180 120 millimeter Hg. She had right lower limb pressure of 220 120 millimeter Hg and left lower limb pressure of 160 100 millimeter Hg. She had no bruits, no murmurs, and some striations were found over upper limb but not over the abdomen. She had an hump over the back. The diagnosis: the patient suffers from refractory hypertension. Refractory hypertension is something uh, in which the hypertension is not relieved even after treatment of three groups of drugs, one of which is a diuretic.
Yes. Yes. Very good presentation, Archit.
Uh, the
Yeah.
tests advised were a CT angiogram, complete from arch of aorta to popliteal arteries to look for Takayasu arteritis or coarctation of aorta, serum creatinine levels for Cushing syndrome, for size, echo-texture, and corticomedullary differentiation, serum aldosterone levels, serum metanephrine levels, serum renin levels, and a renal artery Doppler was done for renal artery stenosis. The modified treatments were clinidipine, olmesartan, chlorthalidone, metoprolol succinate 50 mg, eplerenone 25 mg, and a DASH diet, lifestyle modification, and salt retention was advised. Further treatment options were discussed as FDC to reduce pill burden, and the other options left were prazosin, arcamine, aliskiren, MRA, aldactone, and eplerenone, and loop diuretics. Uh, I'll hand over the hand over the presentation to Pauras to further discuss the pharmacological importance.
Very good, Archit. Very well presented. Very well presented. For a second year student, superb. Superb.
Thank you, ma'am.
Hello everyone, Archit, that was a great presentation. I really liked the way you presented the entire spectrum of drugs available and how the management was done. So I'm just sharing my screen. Uh, It will take a short while. I guess it's visible now. So let us talk about hypertension. So like hypertension is one of the most like very common disorders you see. Like you must be knowing at least one person who has hypertension, right? So before beginning, like we should definitely know what the normal blood pressure is. Although there are various guidelines like ACC or AHA guidelines, but the general like consensus is like less than 120 systolic and less than 80 diastolic is considered normal, and above that it's considered like abnormal, I would say. Like, but various grades are also there. So let us go on. Now the pathophysiology of or the etiology of hypertension is kind of beyond the scope of this because it's very detailed. It is multifactorial, so I won't go into that. We'll directly go into the pharmacology of antihypertensive drugs. So for management of hypertension, we have many kinds of drugs. Like we have like the classification is very huge. So first we have diuretics, in which you have thiazide diuretics like hydrochlorothiazide, chlorthalidone, indapamide. High ceiling diuretics of or loop diuretics like furosemide, torsemide, etc. Potassium sparing, we have which are aldosterone antagonists and stuff like spironolactone, eplerenone, amiloride, etc. Like you can remember these names were being taken in the prescription and the other options of what Archit was speaking. Then we have RAS inhibitors, renal system inhibitors. Now, okay, just refer and correlate to your physiology of renal system. What is RAS? Okay, so in that we have ACE inhibitors, that is angiotensin uh, angiotensinogen converting enzyme inhibitors, in which we have all the prils, captopril, enalapril, lisinopril, etc. We have angiotensin, that is 80 receptor blockers. Here we use 80. There are many types of angiotensin receptor, but here we use 81 receptor blockers. Again, that was taught in physiology. So here we have various sartans like losartan, candesartan, valsartan, etc. Valsartan, telmisartan, etc. So we also have a direct renin inhibitor called aliskiren. Okay, then we have sympathetic agents like beta blockers, that is beta adrenergic blockers in propranolol, metoprolol, atenolol, etc. We have alpha blockers like prazosin, terazosin, doxazosin, phentolamine, phenoxybenzamine, etc. We have mixed alpha plus beta adrenergic blockers, or you could call them beta blockers with additional alpha blocking activity, which are labetalol, carvedilol, and we also have central sympatholytics like clonidine and methyl dopa. So see, like the classification is such extensive that it did not fit into one chart. So the other agents are, or the drugs are, calcium channel blockers, which we discussed earlier. There is verapamil is a phenylalkylamine. Diltiazem we spoke about, which is benzothiazepine, and we have dihydropyridines, all the dipins, nifedipine, amlodipine, etc. And finally, we have vasodilators, in which we have arteriolar dilator, which is hydrolysine, minoxidil diazoxide, etc., and arteriolar plus venodilator, that is nitroprusside sodium. Okay, so we'll discuss quickly each of this in short, very briefly. So first, the overview of site where they are, where these drugs act. So this is the brain. So in the brain we have the VMC center, right? So which is connected to the sympathetic innervation to the blood vessels and to the heart. So in the blood vessel we have various receptors like for we have alpha receptors, so we can use alpha blockers. Vasodilators could be used, like sodium nitroprusside, like NO will act on it. Then we have calcium channel blockers. Again, like we have discussed how it will cause vasodilation previously, so I won't repeat it. Angiotensin receptor blockers and ACE inhibitors, right? So this how it is done. Now we'll discuss it later. In the heart, we have the beta receptors, so we can use beta blockers, and again calcium channel blockers also work. In the kidney, we can use diuretics and alpha blockers. Okay. Now diuretics at each location or the site of the nephron, there are various diuretics. So we'll discuss accordingly. And then kidney releases renin, which is a component of the RAS system, which in turn causes conversion of angiotensinogen to angiotensin 1, which using ACE is converted to angiotensin 2. So ACE inhibitors inhibit ACE, so the RAS is inhibited, and aliskiren is a direct renin inhibitor. So for first we'll go by angiotensin converting enzyme inhibitors, that is ACE inhibitors. So we'll again go by short. Like angiotensin 1 is formed from angiotensinogen. It is then in the lungs, uh, angiotensin converting enzyme, that is ACE, converts it to angiotensin 2, which causes which acts on blood vessel and causes constriction of blood vessel and increases total peripheral resistance, as well as causes aldosterone release. What is aldosterone? Remember, so it will cause the release of aldosterone from the brain, and then aldosterone will cause sodium and water retention, and this both will cause increase in BP. It will also act, as ma'am previously said, hypertrophy and remodeling is an important aspect in MI. So similarly, like so correlate that it will act on heart and work on the hypertrophy and remodeling, and also it will increase the sympathetic activity. So what are the indications or therapeutic uses of ACE inhibitors? You have hypertension, of course we are discussing in hypertension. Acute MI, ma'am spoke about it, right? Congestive heart failure, we'll speak about it. Diabetic nephropathy is something which is very important, and scleroderma, renal crisis. Used, but in exams or so, like it's less dealt with. So why diabetic nephropathy is important in this? I said because ACE inhibitors prevent or delay the development of renal combinations in diabetes mellitus patients. So a person or a patient with diabetes mellitus, ACE inhibitors are preferred. So whenever in exam you have a question of P drug, in which you have to check for the suitability of a drug. So if the history mentions that the patient is diabetic, then your thought process should go towards ACE inhibitors. Again, it will not necessarily definitely be ACE inhibitors, because there are multiple other factors as well. But your thought process should go towards it as well. Now, adverse drug reactions and contraindications may. Adverse drug reactions could be remembered by the mnemonic captopril, that is C for dry cough, A for angioedema, which is very, very important. Like it is very commonly seen, like okay, and cough is also very commonly seen, like, and this adverse drug reaction has a implication which I'll talk about later. Proteinuria, teratogenicity, it is an absolute contraindication. Pregnancy, remember. Hypotension, neutropenia, rashes, itching, loss of taste, which is called as, if you remember from physiology, dysgeusia. Okay, now contraindications. So, like Archit mentioned, that the by whether the renal artery stenosis is there or not was checked. So this is very important, because bilateral renal artery stenosis is a contraindication for ACE inhibitor use, or if a person has a single kidney itself. So of course that even if a single renal artery stenosis is there, it will still be in contraindication. Now, what are the drug interactions of it? So the drug interactions are first with potassium sparing diuretics. That is, if you simultaneously administer these drugs, it can cause dangerous hyperkalemia. Then with lithium, what happens is ACE inhibitors retard renal elimination of lithium, and hence, and lithium is a drug with very narrow safety margin. So, like TDR is done, you will learn in CNS. Uh, so, if we use ACE inhibitors in a person on lithium, or lithium on a person with BP managed with ACE inhibitors, it will cause lithium toxicity and cause dangerous manifestations. So, if you're in a, you know, if you're doing a psych consultation, a person, like correlate it clinically, like a person comes with acute mania or a bipolar disorder, and you that's why physical history is also very important in psychiatric disorders. So the person says that his hypertensive, that is his BP is high, like माझं BP वाढलंय, माझं BP my BP is त्रास आहे, is what the patient will say. So you have to inquire about which drug is being given, because otherwise it will cause dangerous manifestations. Then NSAIDs is important because NSAIDs inhibit prostaglandin synthesis, and hence they promote sodium water retention and chronic use. So they decrease the antihypertensive effect of ACE inhibitors. And lastly, thiazides is that diuretics like thiazides increase the antihypertensive effect of ACE inhibitors by promoting loss of sodium and water. That is, serum potassium levels are maintained by the combination. Okay, then we'll go on by with angiotensin receptor blockers, ARBs. So this is the mechanism of action is very simple. Basically, they're the competitive antagonists of angiotensin 2. Nothing hi-fi. And now I won't explain what is competitive antagonism because it's very well dealt with in biochemistry. So we'll go on with the indications of the therapeutic uses. Of course, we use in hypertension, MI, CHF, and again in diabetic nephropathy for the same reason that it prevents and delays the development of renal complications in diabetes mellitus patients. So, a person with diabetes mellitus, you have to think of ACE inhibitors or ARBs. The alternatives to ACE inhibitors is ARBs when a person is having cough and angioedema. That's what I was talking about. Dry cough and angioedema, important adverse drug reactions which you should remember, because if they are being manifested, then you have an option of changing, like switching from ACE inhibitors to ARBs. Or if MI or heart failure patients are intolerant to ACE inhibitors, then also you can prefer ARBs. What are the adverse drug reactions? Sorry, this is headache. This is hypotension, spelling error. Weakness, rashes, nausea, vomiting. Like everywhere you can write nausea, vomiting. Again, teratogenicity is very important. Absolute contraindication in pregnancy. Hyperkalemia in patients with renal failure, or in patients with potassium sparing diuretics. So this is an important drug indication. So yeah, and in this, as I said earlier, cough or angioedema less likely. So in cough or angioedema, you prefer ARBs. So next, talking about diuretics. So there are various classes of diuretics, uh, and in the nephron, here is the PCT, here is the loop of Henle, DCT, and the collecting tubule. So in the PCT, we have carbonic anhydrase inhibitors. In the loop of Henle, you have loop diuretics. In the thiazide, in the DCT, or the late or the later part of the loop of Henle, you have thiazides, and later on you have potassium sparing diuretics like aldosterone antagonists, right? So this you should remember this size, because this was, I think, very well taught in physiology as well as a clinical correlation. So what are thiazide and thiazide related drugs? So I have told the names of it. So what do they do is, like, I won't explain in detail. So, but this is the early distal tubule in which you have sodium and chloride symport, and this sodium gets pushed into the interstitium by and uh, exchange with potassium by sodium potassium ATPase, and chlorine is passed on to the interstitium by a channel. So this thiazides inhibit this import and hence promote sodium water excretion, and hence that causes decrease in cardiac output and decreases the BP. But on sorry, and also on chronic therapy, it also decreases the sodium concentration in vascular smooth muscles. Hence, the peripheral vascular resistance is decreased, and blood pressure is hence decreased. Indications are hypertension, edema, hypercalciuria, and diabetes insipidus. What are the advantages of thiazide? Is like it has long duration of action. They are very cheap, like you can get it at a very cheap rate. They're well tolerated by elderly. Also, you can like it decreases urinary calcium excretion. So that's why it's of course used in the hypercalciuria. So because of that property, they decrease incidence of fracture in elderly, and also it has synergism with other antihypertensives. This is what I spoke in the drug interactions of ACE inhibitors. So I'll keep on linking with what I said earlier so that you can correlate well. Adverse drug reactions are multifaceted, but it's fine. Like it's easy to understand. Like electrolyte disturbances, hypokalemia, hyponatremia, hypomagnesemia, and hyperkalemia. Remember, everything is hypo except for hypercalcemia. For calcium, it's hyper. Okay, metabolic disturbances, everything do it hyper, like hyperglycemia, hyperlipidemia, hyperuricemia. You also see in importance, so they are not preferred in young male patients, uh, but in elderly they are preferred. So you can correlate how age is important in clinical medicine, like clinical aspects. And see also sometimes find skin rashes, photosensitivity, and of course nausea, vomiting, diarrhea by default, you right. And it is a avoid, like it's not a absolute contraindication, but it is avoided in pregnancy as thiazides reduce placental perfusion. And drug interactions, I spoke about it in ACE inhibitors. Loop diuretics, what do they basically do? That is we have sodium, potassium, and two chloride uh, this pumps in the tubular cells in the loop of Henle. This NKCC we call. So this loop diuretics inhibit this co-transporter, NKCC co-transporter. Okay, so the indication is initial stages of renal, cardiac, and cerebral edema, acute pulmonary edema, hypertension, and blood transfusions. When, but however, in hypertension, it's not very well used because of short duration action, except in patients with renal or cardiac failure. But it's remember diuretics are very important for this pulmonary edema, which I'll be talking about in a in the later part of the seminar. Again, electrolyte disturbances we have, again same hypokalemia, hyponatremia, hypomagnesemia. However, calcemia here is hypo. So remember the difference between thiazides and loop diuretics. And also hypersensitivity, skin rashes, eosinophilia, photosensitivity, and ototoxicity. Very, very important. Because I'll talk about it like in drug interactions also, we'll understand about it. Right. So we have digoxin aminoglycosides. It the important drug interaction with aminoglycoside is that both are ototoxic. So when you administer them together, there could be severe ototoxicity and could cause hearing loss and other manifestations. NSAID same as earlier, lithium same as earlier. So I'll just move on. Very important now, beta blockers. Beta blockers is one of the most important drugs in hypertension management. Like you can, you must have heard like metoprolol so frequently. So what are beta blockers? Basically, in the ANS we have the sympathetic and parasympathetic system. In sympathetic, we have the adrenergic system and the cholinergic system, and in the adrenergic system, we have alpha receptors and the beta receptors, right? So, beta blockers are drugs which block or inhibit the beta receptors. And the classification is, I won't go in detail of it because it's actually a ANS topic rather than CVS topic. However, there are first generation, that is non-selective beta blockers like propranolol, timolol, pindolol, sotalol, etc. Second generation, that is beta 1 selective adrenergic blockers. That is atenolol, acebutolol, bisoprolol, esmolol, metoprolol. Metoprolol is very commonly used. Uh, yeah. And third generation, we have beta blockers with additional vasodilatory effects, which I spoke about in the angina part. Labetalol, carvedilol, and beta 1 selective, like beta 1 blockers with additional vasodilatory effect is like betaxolol, celiprolol, and nebivolol. Now, like which one? There's a huge amount of information on the pharmacokinetics of like which more effective in what condition. But I'm not going to discuss more on that. I'll be talking more about the clinical aspects of it. There are also two blockers, but it is not related to cardiovascular. It is like it is related to respiratory. Like in respiratory, beta 2 agonists are used in asthma and stuff. So yeah. So, beta blockers are mainly useful in young hypertensives with high renin levels, patients with associated conditions like angina, post myocardial infarction, migraine, and psychosomatic disorders, and patients receiving vasodilators to counteract reflex tachycardia. So, beta blockers block beta 1 receptors, causing decrease in heart rate, decrease force of contraction, decrease cardiac output, thus causing decreased BP, decreased renin release to decrease BP, and decreased sympathetic outflow naturally. So that's why they decrease BP. Indications are hypertension, angina prophylaxis, and MI, arrhythmias, heart failure, pheochromocytoma, glaucoma, migraine prophylaxis, hyperthyroidism, essential tremors, acute anxiety states, alcohol withdrawal, HOCM, and aortic dissection. Now, dissection, sorry. In this, like earlier I said, like this is important, this is not. But in beta blockers, all these therapeutic uses are very, very important because like beta blockers are used in all of these. So like remember all of these indications well. In adverse drug reactions, it's just a extrapolation of your mechanism of action. So in CVS you have bradycardia, like because heart rate is decreased, right? Heart rate is decreased. So bradycardia, heart block, CHF precipitation, worsening peripheral vascular disease, Prinzmetal angina exacerbation. Respiratory system में patients with asthma and COPD. Hence, it is absolute. Like, I won't call it absolute. I don't remember, but it is a contraindication in asthma and COPD. Then you have sleep disturbances, hallucinations, fatigue, mental. Like, that's fine. Very important interaction is with insulin sulfonylurea here. So what happens is beta blockers mask the signs and symptoms of hypoglycemia due to these drugs. So what happens is the patient can go into hypoglycemic coma or the recovery from hypoglycemia state. Muscular weakness and tiredness. In the action, I did not speak about it, but because also have action on muscles. Also, we have withdrawal terms of you beta block. It cause withdrawal. There are also alpha blockers in non-selective. That is, it acts on both alpha 1 and alpha 2, and the selective is alpha 1. So non-selectives the lamine. They cause vasodilation, fall in BP due to alpha 1 blockade. However, noradrenaline release is increased due to presynaptic alpha 2 blockade. So this noradrenaline in turn can cause increased BP and so. But just remember, like I don't have the time to explain alpha blockers in detail. Prazosin, terazosin, doxazosine, block selectively alpha 1 receptors by competitive, so cause vasodilation and fall in BP. So alpha 2 are not blocked. Hence, there is no increase in that's why tachycardia is minimal. So indications are again pheochromocytoma, hypertensive emergencies, very very important. Hypertension testosterone. BPase is very important comorbidity. Uh, okay, adverse drug reaction again tachycardia, tachycardia, angina and MI precipitation, and you see first dose phenomenon in prazosin, wherein once you give the first dose of prazosin, it causes some clinical adverse reactions. That's why the first dose of prazosin is given as low as 1 mg, and then it's increased. So clinically, how do you choose a drug? So there is a theoretical choosing model guidelines for this. So first you ask the patient for the age. Of course, you ask other things as well. But for a person with no comorbidities, let us consider you ask for age. So if the age is less than 55 years, we give ACE inhibitors or ARBs. As ma'am said, ACE inhibitors or ARBs and not both, because the combination does not reduce poor outcomes. Like they don't have additional benefits of combining. Okay. However, it leads to more adverse drug reactions of risk of vascular events or renal dysfunction. So, the in your exam, if a question is asked about this rational, whether a fixed dose combination is rational or not, this could be a possible question. ACE inhibitor plus ARB. Okay, or if the patient is more than 55 years, calcium channel blockers are given. Again, this is just a theoretical model. In clinical practice, there are many more factors to consider, like adverse drug reaction profile and stuff, comorbidities and stuff. So you have to think about that. If there is inadequate control after 1 month, then we give ACE inhibitor or ARB, like one of those, plus calcium channel blocker. Again, if no control after 1 month or inadequate control after 1 month, we add thiazide. If inadequate control after 1 month, we label it as resistant hypertension, in which we give ACE inhibitor or ARB, one of those, plus calcium channel blocker, plus thiazide, plus spironolactone. Okay. Now, comorbid condition, this is very, very important for your clinical practice. And if you're just thinking about your exams, then P drug list may, or in this, in P drug list, yeah, or in this rationality of FDC, this is very important. Angina post MI में beta blockers, inhibitors और ARBs. Heart failure में ACE inhibitors, loop diuretics और ARBs. Diabetes mellitus, I explained why. ACE inhibitors और ARBs. Post stroke में this. Bronchial asthma में calcium channel blockers. You can't give beta blockers, remember. Hypertensive emergencies में sodium nitroprusside, labetalol, nitroglycerin. BPH में selective alpha 1 blockers because they act on the prostate as well. And pregnancy में nifedipine, labetalol, alpha methyl dopa or hydralazine. Personally, I have seen labetalol and hydralazine used more. I don't know the reason for it, but I have seen labetalol used more. Special conditions where drugs are definitely, like, drugs are avoided, or they may even be absolute contraindication. For example, bronchial asthma or COPD में non-selective beta blockers. Peripheral vascular disease में non-selective beta blockers. Same for diabetes mellitus. So in this, I like it's basically, if a person comes with diabetes mellitus, an elderly comes with diabetes mellitus, you don't give beta blockers, you give other options. Hyperlipidemias में thiazides and beta blockers are preferred. Gout में thiazides, and sexually active males में alpha 1 blockers or diuretics, because I remember I told about impotence possibility in ACE inhibitors, in thiazides. So remember that. Now, lastly, talking about the hypertensive emergency versus urgency, very important concept. What is emergency versus urgency? Basically, when you have very high BP, that is more than or equal to 220 by 120, 220 or 125, and end organ damage, that is, you see retinal damage or renal damage or peripheral vascular damage, you label it as hypertensive emergency. And if there is, sorry, this is a typing error, it should be without. I'm so sorry for the typing error. If there is high BP but no end or organ damage, it's urgency. In hypertensive emergency, like, it's an emergency state, right? So logically you will use IV drugs, or that's what you can remember. In urgency, you oral drugs are preferred. So what are the drugs of choice? Nicardipine overall in emergency. However, in pregnancy, labetalol is used. Labetalol, like, you can also correlate to preeclampsia and eclampsia. Labetalol is used very frequently. And other drugs are available like hydralazine, esmolol, furosemide, and so on. I'll not. And in urgency, drug of choice is clonidine, which is, if you remember, central sympatholytic, and other drugs available are captopril and nifedipine. With this, I'm done with hypertension, drugs in hypertension. Sorry for overshooting the time, but hypertension, I found it very important. Uh, so I'll just hand over to Shraddha ma'am.
Thank you, Pauras. Very nice in-depth presentation. Kushal is having some question. You can ask us. We can unmute him. Yeah. He's left the meeting. All right. Okay. So basically, whenever I see a patient of a hypertension, this is a real case from my private practice. So basically, this lady, whenever you see any patient of hypertension who is coming to you for the first time, you have to find out what is the age of the patient and whether it is an essential or primary hypertension or whether it is a secondary hypertension. Essential or primary hypertension means somebody who is age related, or diabetes is there, obesity is there, metabolic syndrome, what we call as, or syndrome X, correct? And secondary hypertension, especially if a young, lean, thin individual is coming to me at a very young age with a hypertension, I'll try to find out if there is any cause of secondary hypertension and what are the different types of secondary hypertension. So once Archit was presenting the case, Nishit, he has written all the investigations. So basically, those investigations are something which you do for workup of a secondary hypertension. Renal parenchymal conditions like chronic kidney disease. Renal vascular causes can be there, like renal artery stenosis. Then go above the kidney in the adrenals. So it can be adrenal cortical and adrenal medullary problem. So adrenal cortical, so it can be either a pheochromocytoma can be there, Con syndrome can be there, which can present like a or it can be adrenal dystrophies can be there, adrenal dystrophies can be there, which can present as a hypertension. Then once you are done with the kidney analysis by USG KUB to look for that size of the kidney, to look for the corticomedullary differentiation, and once you are done with the renal vascular with a renal artery Doppler, okay, then you talk about then you send the investigation for the FEO workup, which are like serum metanephrines and urinary metanephrines, and you do a scans. After the renal and suprarenal is done, then the other causes of secondary hypertension, you think about thyroid. So both hyper and hypothyroid can cause hypertension. Hyperthyroid causes more of a systolic type of hypertension. Hypothyroid causes more of a diastolic type of hypertension. And that is why what you have to send to this patient is TSH, T3, T4 level. Sometimes Hashimoto's thyroiditis can also present with a hypertensive surge in early period. Okay. Then once the thyroid is done, then Cushing's I forgot. So Cushing syndrome is something either a iatrogenic Cushing because of the too much steroid use, or it is an endogenous Cushing because some problem either in the adrenal or it is some problem in the pituitary, and because of which patient can have hypertension. So we often send a serum cortisol level. But like when Harjit was presenting the case, he said that she had some striae, she had a hump in the back, which is called as a buffalo hump. And that is why serum cortisol is something which you will send for a Cushing's workup. So we spoke about adrenal, we spoke about kidneys, we spoke about thyroid, we spoke about the renal vascular. After that, what you have to talk about is the major vessels. So when you talk about the major vessels which can cause or which can present like a hypertension is, Srushti, basically Takayasu arteritis is something which can present, because what is Takayasu arteritis? It is a large vessel vasculitis which is there, and then there can be a renal artery associated stenosis with that, and there can be stenosis of the major vessels. So for that, or else it can be a coarctation of aorta. So that is why it is an importance when you say in the radial examination, pulse examination, no radial or no radiofemoral delay. Why do you say that? Because you want to find out if there is any radiofemoral delay because of postductal coarctation, radial delay because of preductal coarctation, or if there is Takayasu arteritis, which is also called as a pulseless disease and can cause a hypertension. So that is why I had asked for a CT angio in her. So these are the secondary causes of hypertension that you have to rule out. You should just go through the drug list that patient is having, like the licorice, gestamad, what you call in Marathi. So that, NSAIDs. So these are few, or the IV drugs like cocaine or something. So these are few which can cause amphetamines. So these are ones which can cause a hypertensive surge in a patient. So go through that. Okay. So after that, there are some rare causes, or not rare causes. This female was very obese. So, OSA, or obstructive sleep apnea, if you have heard of those people who are very obese, they snore when they sleep, correct? So, that is something which is a very, very important cause of hypertension and refractory hypertension. And for that, you have to do a weight reduction. Okay, so that is how I classify primary or essential hypertension and secondary hypertension. Now, Porus has in detail told about all the drugs. I'm not going to repeat that. He also said that below 55, you start with RAS blockage, above 55, calcium channel blocker, because calcium channel blocker are something which are going to act on the arterial level and reduce the stiffening, and which is going to give the vasal relaxation, or relaxation of the smooth muscles of the vessel. And this atherosclerotic and stiffening is something which is very common issue at that age group, 55 above. That is one of the reason why we stick to this. Whereas below 55, you go for a RAS blockage. Now, whenever you see a patient and you check a BP, you check with a mercury sphygmomanometer. Do we have other options to check? So yes, we have automated machines. We have what we use at home, like Omron machines, and then we have some, which is called as a HBPM, home BP monitoring. And then you have aneroid manometers, which are like a liver and liver system, which is there. So these are something you must have seen, a small watch dial kind of manometer, BP apparatus, and with a cuff. So that is aneroid. That is also commonly used. It's very handy. But then there is concept of something called as a white coat hypertension and masked hypertension. So you have to understand that, in refractory hypertension. So this lady who came to me, and every time I'm finding, you can see all the four limb BP, and it is important to take a four limb BP, especially when you're checking for the first time, to find out if there is Takayasu arteritis or coarctation of aorta. In coarctation aorta, the lower limb BP will be low, upper limb will be high. In Takayasu arteritis, you may get a difference in the two limbs, and that is why you should find out the four limb BP. All right. Auscultate for a bruit of a renal artery in a periumbilical position. Auscultate for a bruit over the carotids. That is how you will find out if there is any arterial obstruction is there. So now there is something called as a white coat hypertension. Many patients who come to you in clinic and you take a BP, and many times you find out that BP is very high, but the patients are very sure that when they take the BP by their home instrument, the BP is normal. So what is happening? And that is something which is called as a clinic environment, a doctor, 30 medical students standing around, too many patients, chaos going around. So that is why there can be a false elevation of a blood pressure in the clinic in front of that white coat. That is what is called as a white coat hypertension. Okay. Then there is something called as a masked hypertension, MASKED, where your clinic BP is normal, but then there is little bit elevation of BP at home, which is especially found in elderly patients. And not much of a cause is given for that. But then how do you diagnose that? Because these patients are having a end organ damage, which you are not able to explain why, if the BP is normal, like a AKI, or like a, so not AKI, like a CKD or proteinuria, hypertensive retinopathy, left ventricular enlargement, all these things are there. And you are thinking the BP is not much, then why this? So the home BP is something which is high. Then there is something called as a refractory hypertension, which is Murtuza our case. So if you see, this lady was already on a calcium channel blocker, she was already on a diuretic, and she was already on a RAS blockage, and one more drug was there. Despite that, her BP is in the range of 220, 180. And that is why, that is what is called as, when the patient is on three drugs, three is important, or three or more. And when the patient is on three or more drugs and maximum dosages, and still the BP is not controlled, that is what is called as a refractory hypertension. And when you have such cases of WCH, mass hypertension, refractory hypertension, you do something called as a ABPM, which is ambulatory blood pressure monitoring. So what is that? So when you are checking a BP nishchit, that is something which you are checking at a OPD basis. That is a one-time reading which can have many factors which can increase or decrease the blood pressure. Like if a patient has had a tea or coffee or smoking or with a full bladder, the BP is going to come high. And that is why, especially in these cases, especially young patients, what you will do is there is something called as an ambulatory blood pressure monitoring. So the instrument costs around 2 to 2.5 lakhs according to the software advances. And it's a very small instrument, and there's a BP cuff. And so you send a patient with that instrument, the cuff attached to the patient, and then that BP, that machine will keep taking the BP every 15 or 10 minutes, however you want it, over a span of a 24 hours. When the patient is in his normal environment, doing his normal work, doing at home, when he is not stressed out in front of you. And then when the patient comes back, then what you do is you take out that machine, you load it in your laptop and just see all the readings. You will get the maximum systolic, the maximum diastolic. There is something called as a night dipping. So when the patient, when the physiologically we sleep, the BP goes down, correct? And that night dipping is something which is reversed in hypertensive patient. It does not go down, it is still high. So these are the things which we look up and in ambulatory BP monitoring, and then you will be able to really find out कि नहीं ये WCH नहीं है, इसका BP बाहर भी ज्यादा है, या फिर ये WCH है, इसका BP घर में हमेशा अच्छा है. Are you understanding this? And that is how you will be able to find out. Okay, so that was ABPM. There is another thing which I want you people to know is something called as a CABP. So CABP is central aortic blood pressure. So it is said that your end organs like retina, kidney, heart, all of them, brain. So these end organs are facing the BP because which is actually at the level of the aorta. The damage is actually proportional to the blood pressure which is at the level of central aorta. But do we check the central aortic blood pressure? No, we cannot do that invasive central aortic blood pressure monitoring. And that is why what we do is there is a non-invasive method of central aortic blood pressure monitoring with a principle which all of you should know, that is applanation tonometry principle. It is applanation tonometry principle. It is a non-invasive method. Again, it's a very costly instrument causing 2.5 to 3 lakhs, and it takes 7 minutes for that particular patient to give us the reading of the BP. It is also put at the brachial artery level only. It is not that at the aortic level you cannot put non-invasive, correct? And then that is another thing. So basically, these are different methods of checking a BP. I spoke about essential. I spoke about the secondary hypertension. Pauras has already talked about all the group of drugs which are there. And then after that, there is something called as a surgical management. So there is DASH diet is something which is what? It is a diet which is against approach to stop hypertension. That is something which is DASH. D, so dietary approach to stop hypertension. So ask patient to take more of a vegan diet and more of a MUFA diet, and diet which should be less in the bakery products. So that is something which is important. Porus has already discussed the all the indications, the contraindications very beautifully, and we have also discussed hypertensive emergencies and urgencies. So basically, emergencies are something which are with end organ damage like hypertensive encephalopathy or left ventricular failure with pulmonary edema, or it can be a stroke, or it can be a rapidly progressive renal failure, AKI. And you have or diabetic retinopathy, or hypertensive retinopathy, which is very high grade. So basically, you have a very low time window to control the blood pressure in these hypertensive emergencies, whereas urgencies are without the end organ damage, and you have a much more time window. So that is why, Nishit, what you will use in hypertensive emergencies, you cannot write tablet amlodipine 5 मिलीग्राम ले लो जाके घर जाओ, ऐसा कभी नहीं कर सकते हम. And that is why you have to be very aggressive and you have to give injectable antihypertensive, like, as you correctly said, labetalol. And then one of labetalol is expensive, but so another one which you can use it, 20 milligram of labetalol costs 280 rupees. And that is why we use something called as a NTG, nitroglycerin drip effect. Superb antihypertensive effect we get, super pulmonary edema, especially LVF is the presentation. And but that is, there is something called as a tachyphylaxis for the NTG. And what is tachyphylaxis? This is a very important term from pharmacological point of view, that over second day or third day, the dose of NTG which was able to achieve the antihypertensive effect on day one, the same dose is not able to achieve the antihypertensive effect on day 2 or day 3, and more increment in the dosages is required to achieve that same antihypertensive effect. That is something which is tachyphylaxis. Okay, another IV drugs which are available in India are, we use enalprilat also. So enalprilat, NTG, labetalol, and then sodium nitroprusside is something which is also used, not very commonly, but NTG labet is very commonly used. And then after that, I'll just end up with, there is something called as a surgical management of hypertension. So when Archit was presenting, he wrote that patient had underwent a renal sympathetic denervation therapy. So basically what you do in that, there are two trials. There is Simplicity Hypertension 2 and 3 trials. So Hypertension Simplicity 2 trial gave positive result, Simplicity 3 did not give good results, and still it is under evaluation. So she underwent that, I think in Hinduja she underwent. And basically you do a radio frequency ablation of a sympathetic plexus around the renal arteries. So that is what is one modality, surgical, that is renal sympathetic denervation. And another modality which is there is a baroreceptor activation therapy. So novel baroreceptor. So what you do is you implant a device and then basically you stimulate the baroreceptors, and that is something which reduces the blood pressure in a resistant hypertension. Again, I'm saying that these surgical managements are something which are very rarely seen. In fact, I'll agree to this, that this was the first patient of surgical management of hypertension I have read since the time I read it from Harrison, long back. And then you must be thinking, should I give aspirin to prevent stroke or IHD in this patient? No. So basically, secondary prevention is something, unless primary prevention you should not do. Secondary prevention is something which you can do. प्राइमरी प्रिवेंशन के लिए नहीं देना चाहिए. मतलब अगर किसी को सीवीए नहीं है, आईएचडी नहीं है, पर हाइपरटेंशन है, उसको एस्पिरिन चालू करे, क्या क्यों उसको सीवीए और हाइपरटेंशन नहीं होना चाहिए फ्यूचर में? ना, you should not do that. So primary prevention is something which you should not do. Secondary prevention, who already have had a CV or IHD, of course you will have to do either a DAPT or single antiplatelet as per the time since when the event has occurred. All right. So basically, A, B, you have the ACE inhibitors, ARBs, you have the beta blockers, you have the calcium channel, you have the diuretic. In young less than 55, we generally start with RAS unless there is a contraindication. Elderly, calcium channel is something which is preferred. And then you start with one group of a drug. But if it is a stage 2 hypertension, there are staging of hypertension. Okay. So if the BP is more than 140/90, because every group will have, that particular therapeutic window कि उससे उतना ही बीपी कम होगा. अगर आप 180 के पेशेंट को 180/120 के पेशेंट को एक ही ग्रुप ऑफ ड्रग दोगे, RAS blockage, then BP is going to get reduced only by 20 ka margin. And that is why in second stage or third stage, you start with a dual antihypertensive therapy from the beginning itself. Okay, so after ACE, you can add up a calcium channel blocker, however you want. You can add diuretics. But then after you finish off with RAS blockage, calcium channel blockage, and diuretic, then only the role of beta blocker comes in hypertension. But when the patient is having ischemic heart disease, then the role of beta blockers goes very high. Okay, because beta blocker and ischemic heart disease, you need beta blocker in ischemic heart diseases, as we said that the rate reduction. Okay, so basically आफ्टर दैट बीटा ब्लॉकर फिर भी नहीं कंट्रोल हुआ है तो आप अल्फा ब्लॉकर प्रेजोसिन का यूज करो. उसके बाद आप क्लोनिडिन सेंट्रल सिम्पथोलाइटिक व्हिच आर क्लोनिडिन, मॉक्सिनिडिन, you can use it, and then aliskiren. Again, aliskiren I have used for the first time in my life. So direct renin inhibitor, again you should not give another RAS blockage when you are giving this direct renin inhibitor. Okay, So that is all about hypertension. Ask the patient for a reduction in the salt intake, exercise and lifestyle modification, weight reduction. And there was one study which was done, script study. So there was one study which was done for to look up for the salt intake in different locations of the from India itself, and it was really disturbing study to know that four regions from India, basically north was north, east, west, and south. So north was the highest. North was consuming the highest salt. I think it was somewhere around 14.1 grams per day. Grams per day. And then least, I think, was from east and from south. So that was around 9.8, 9.4. And west, even us. So west is something which is consuming almost 10.1, but north was something which was consuming the most salt. And that is why salt reduction. And there is a role of potassium. So now if you see the newer salts which have the potassium added, okay, low sodium salt or potassium salts are something which are available, but there is some role which is about the potassium which can be given. So and dash diet is something which is important. Smoking, even the electronic cigarette smoking is something which is, no, it is not going to reduce the harm. Okay, so these are the things about hypertension that we should know. Echocardiography, fundus examination is something, 2D echo, ECG, fundus examination, urine routine for proteinuria. All these are all the workups. So these are all the workups which you should do for your hypertensive patient at a regular interval, and try to find out if there is secondary cause of hypertension. So that's it all about, not all, but that's it what I can give in 10 minutes maybe about the hypertension. Thank you. So now what we will do is we will go ahead with the next presentation by Aditya Nair on heart failure case. Aditya, it's all yours.
Yeah, hello, am I audible?
Yes.
Okay. Okay, so is my screen visible?
Yes, yes.
So welcome to a presentation on heart failure. Me along with Pauras Mhatre and Dr. Shraddha More ma'am have made this presentation. Okay. So Mr. ABC, a 45-year-old male, works as a bus conductor at Lal Bagh. He came in with the chief complaints of breathlessness on exertion, fatigability, and swelling of the legs. So the history of present illness. Now, hello. Yeah. History of present illness. The patient presented with paroxysmal nocturnal dyspnea, which is intermittent awakening, due to which he had intermittent awakening in the night within 2-3 hours of sleep. Dyspnea on exertion, which progressed from the New York Heart Association grade 1 to grade 2, ultimately to grade 4, which is dyspnea at rest. Now, bilateral painless swelling of the lower limbs without periorbital edema, ruling out renal problems, or abdominal distension, ruling out liver problems. So mainly indicating cardiac abnormalities. Now, past history, the patient had a past history of diabetes, hypertension, coronary artery disease, dyslipidemia, and obesity. Patient underwent PTCA, which is percutaneous transluminal coronary angioplasty in the left anterior descending artery 2 years back. Personal history, he's a chronic smoker with a 1-pack year history. Alcoholic, he drinks 180 ml of country liquor per day and disturbs sleep due to paroxysmal nocturnal dyspnea. Now, on examination, the general examination were pallor, elevated JVP, pitting type of pedal edema, blood pressure, high blood pressure showing 140 by 90 milligram of mercury, and a pulse of 90 per minute. Now, on respiratory exam, crepitations were heard, and on the cardiovascular exam, the S3 sound was heard. Now, the investigations done were 2D echo showing left ventricle ejection fraction of 25%, which is considerably reduced, and regional wall motion abnormalities. Now, the blood test also showed elevated NT-proBNP. The hemoglobin of the patient was decreased to 7 gram per deciliter, and the HbA1c was elevated around 10%. This is the ECG of showing a old myocardial infarction of the patient. Okay. The diagnosis: Mr. ABC with a reduced ejection fraction of 20%, bilateral pitting edema in the lower limbs, and dyspnea, and a history of smoking, alcoholism, diabetes, dyslipidemia, and coronary artery disease, is diagnosed with acute decompensated heart failure. The treatment given to the patient was a Lasix injection, furosemide, 40 milligrams, tablets spironolactone, which is a mineralocorticoid agonist, and a sacubitril valsartan, which is an ARNI. And for dyslipidemia, he was started on tablet atorvastatin. For coronary artery disease, he was given aspirin and clopidogrel, and the tablet metoprolol was withheld in case of heart failure. Uh, and for anemia, he was given an injection of ferric carboxy maltose 1 gram in 50 cc NS over 1 hour. And for the diabetes, he was given empagliflozin, which is a SGL2 inhibitor. So it prevents the sodium reuptake along with the sugar in the renal tubules, which is beneficial for heart failure. And also insulin degludec injection was given because of high elevated HbA1c. Okay. So this was my presentation. Now I hand it over to Pauras.
Yeah, very well presented, Aditya. Very good. Yeah, Pauras.
That was a great presentation, and I especially like the way you included in the history about New York NYHA scale and stuff. So it
Thank
was
you.
like, yeah. So talk about heart failure, congestive heart failure, congestive cardiac failure. Wait a minute, I'll just, yeah. So let's talk about the pathophysiology, like about how the pathophysiology of cardiac failure. So basically, what happens is there could be forward failure or a backward failure. So backward failure, it could be distended veins with increased preload, or in forward failure there is narrowed arterioles and arterioles with increased afterload. That in turn causes decreased cardiac output, which causes reduced renal blood flow, which causes sodium water retention and causes edema. And reduced renal blood flow will also cause increased renin angiotensin activity, which will again cause sodium water retention and thus edema. So, what are the various drugs available in this? So, we have first we can work on each step we can use. Like, that's the beauty of medicine, that once we know of how a thing works, that's why we find out how a thing works, right? How a disease is caused, right? So once we find out that, we can work on each and every step of it, right? So in this, there's increased preload. So what we can do is used nitrates, like vasodilators, so or ACE inhibitors or ARBs, which will decrease the preload. Or we could reduce the afterload, again ACE inhibitors or ARBs or other vasodilators. Here we can decrease cardiac output as well, which is by digitalis, that is digoxin or dobutamine. We could increase the renal blood flow by dopamine, and the sodium water retention could be prevented by promoting sodium water excretion by diuretics, or we can decrease the RAS system activity by ACE inhibitors or ARBs. So there are so many drugs like hypertension. There are many drugs in heart failure. So in this, we have inotropic drugs like cardiac glycosides like digoxin, digitoxin, like both are different. OABN. Then sympathomimetics like dobutamine and dopamine. PDE3, that is phosphodiesterase 3 inhibitors like inamrinone and milrinone. We have RAS inhibitors like ACE inhibitors and angiotensin receptor blockers, which you have spoken earlier, so I won't repeat it here. Diuretics, that is high ceiling, like loop diuretics and thiazide diuretics. Again, I have spoken about it, so I won't repeat it here. Vasodilators, we have spoken about. Uh, not in great detail, but we have spoken about CCBs and nitrates earlier. So we have venodilators here. Sodium nitroprusside we haven't discussed, but I won't discuss it for now. And we also have arteriolar dilators like hydrolysin. Again, I won't discuss it now. Beta blockers we have discussed in great details, and we also have aldosterone antagonists, which I should have discussed with diuretics, but due to the limited time, I did not take it. But it's very easy to understand, so we'll understand by reading as well. So what I'll be discussing is cardiac glycosides, PD3 inhibitors, and one more class of drugs called as BNP analogs. In sympathomimetics, I haven't discussed before, but I won't discuss it now because dopamine, etc., is more of ANS pharmacology. So I'll keep it for other time. So talking about vasodilators, so we could have mainly venodilators like nitrates, which will cause peripheral pooling of blood. I have explained it earlier how, and thus it will decrease the ventricular end diastolic pressure and volume. And okay, and in arteriolar dilators, we have hydrolysin, minoxidil, nifedipine, and nicorandil, in which decrease the peripheral vascular resistance, decrease afterload, increase in stroke volume, and improve tissue. It will cause improved tissue perfusion. Now there are mixed vasodilators as well. Means they will reduce both preload and afterload, which are ACE inhibitors, ARBs, and sodium nitroprusside. So that was just basic in short, because I have spoken about it earlier about nitrate in great detail. Talking about cardiac glycoside. So yeah. So talking about cardiac glycosides. So what are cardiac glycosides? Basically, they are the extracts or the extracts I could call or like whatever. The source is of a plant called as white fox glove, digitalis lanata, etc. There are 2-3 plants, but digitalis here. So this is a very quiz type of question. So white fox glove, just remember. So what is the mechanism of action? So we have the sodium potassium pump. So what digoxin does? It inhibits sodium potassium pump. So you remember, like, what is the function of sodium potassium pump is to reverse uh, like depolarization. So what will digoxin do? It will decrease the sodium influx and decrease the potassium influx. What it will cause is increased intracellular intracellular sodium is increased, and extracellular potassium is increased. Now I said about potassium because one of the ADRs of digoxin will be hyperkalemia. So you can think on the lines of mechanism of action. So what happens is that the potassium outside the cell binds to the sodium potassium pump and limits the binding of digoxin. Like this will cause like decreased binding, right? So I'll explain more on it later. So again, what happens then on an intracellular level? What happens? There is increased intracellular sodium, right? So it blocks the sodium calcium exchange pump. That will cause increase in the intracellular calcium. Now, thus ultimately digoxin increases the intracellular calcium. So by like voltage sensitive, so you get it right. So this by sarcoplasmic reticulum, it will cause the release of calcium from sarcoplasmic reticulum, which will cause the contraction. Remember the physiology. I don't have the time to explain in detail, but you can correlate to you have recently given exam, so you'll definitely remember cardiac contraction, how is it done, right? So basically, in short, digitalis binds and inhibits sodium potassium pump, which causes increased intracellular sodium, decreased extrusion of calcium, thus increased intracellular calcium, uh, thus increased calcium uptake and storage in sarcoplasmic reticulum. Thus, increased amount of calcium is released during each excitation potential from sarcoplasmic reticulum. Thus, increased availability of calcium for excitation, contraction coupling, thus increasing myocardial contractility, which is called as inotropic effect. As like you will remember that. So this all of this will cause increased cardiac output. So what happens? Like digitalis, we know we came up by till this step. So what will happen by increased cardiac output? It will improve the circulation for sure. So there will be increased tissue perfusion. So it will correct the hypoxia. Again, there will be increased renal blood flow. Hence, increased sodium and potassium excretion happens, and hence it will relieve edema and dyspnea. And there will be compensatory sympathetic overactivity is withdrawn. So we'll talk about digitalis or digoxin. So the indication of therapeutic uses are heart failure, atrial fibrillation, atrial flutter, or PSVT. We'll talk about this later, but heart failure is an important use. Adverse drug reaction, the earliest adverse drug reaction or the symptoms of digoxin toxicity is anorexia and nausea, vomiting, right? So clinically you should suspect if a person on digoxin come presents with nausea, vomiting, then headache, confusion, various CNS ADRs are there, gynecomastia, hyperkalemia, I explained how, and skin rashes are there. Cardiac may literally any type of arrhythmia can happen by digoxin, except for atrial flutter and Mobitz type 2 heart block. Now again, remember the types of heart block which you studied in physiology. Type 1, type 2 में Mobitz type, you have heart block 1 and 2, like secondary heart block, you have Mobitz type 1, 2, etc. And we also have ventricular premature beats, pulses by Gemini, and ventricular tachycardia. I'll like because it's clinically important, I'll like to explain how. So what happens here is increased intracellular calcium, right? So what happens? It produces another depolarization. Okay. So which will cause a delayed after depolarization. It's like it's a like you can read more about it. Delayed after depolarization. So what happens? This leads to further increase in calcium inside the cell, right? So calcium is going on increasing. So what will happen? An extra systole will take place. So then if the extra systole is repetitive, then it will cause ventricular bigeminy or trigeminy, which is which are ventricular bigeminy is most common digoxin induced arrhythmia. Treatment is potassium. Okay, then if further increase in calcium, then it will cause VTAC, ventricular tachycardia. If further increase in calcium, then it will cause VFib. Okay, so the treatment for VFib and VTAC we'll talk later, but in short, it's lidocaine or amiodarone is drug of choice, but in severe cases, digibind is the drug of choice. The next class of drugs, I forgot to say, contraindication is WPW syndrome, Wolff-Parkinson-White syndrome. And since there is so much, there's a narrow margin of safety for this drug, therapeutic drug monitoring, therapeutic drug monitoring is done for digoxin. Drug interactions, I think you can read by yourself, but these are the various drugs with which it interacts. There are PD3 inhibitors, the phosphodiesterase 3 inhibitors. So sorry. This basically is, yeah, like I know, these are I know, yeah, I know dilators. So the mechanism of action is it blocks metabolism of cyclic AMP in blood vessel and heart, which will cause contraction and all like positive inotropic effect, and as well as in blood vessel causing vasodilation. So what PD3 usually does, it metabolizes cyclic AMP, right? So if the metabolism is reduced, cyclic AMP will increase, right? So what are the drugs? Drugs are amrinone and milrinone, right? So what are the side effects? Nausea, vomiting, arrhythmias, thrombocytopenia, and hepatotoxy. However, thrombocytopenia is only for inamrinone and not milrinone. Then we have something called as BNP analogs. So what usually happens is when there is increased blood pressure, so there is an increased stretch in the renal blood vessel, atrium, and ventricles. So these in turn release some molecules like urodilantine for renal blood vessel, ANP for atrium, and BNP for ventricles. So this in turn will cause a negative feedback on RAS, that is, it will regulate RAS, which will cause increase in cyclic GMP and smooth muscle relaxation, causing vasodilation, natriuresis, diuresis, and hence BP will release, decrease. So what we have done is that we have found analogs to it, like ularitide, carperitide, and nesiritide, of which these two aren't approved, but nesiritide is approved for use. So we have found BNP analog. So it will cause this, and decrease like in BP, and then like it could be used for like it is approved for use along with valsartan for heart failure. So now it's important to understand how acute cardiac failure is treated. So before that, we need to know pathophysiology. So for the most common cause is MI. So MI is acute insult to myocardium, right? So that will cause decreased contraction of left ventricle. So that will cause stasis of blood in left ventricle, which will cause congestion, which will cause fluid leaks, and that's why it will cause pulmonary edema. Very important manifestation of acute CHF. So what is the treatment? Before treating CHF, pulmonary edema is treated because it's very life-threatening. So the first drug used is furosemide and morphine to control pain and stuff. But furosemide is the first drug which decreases the afterload and preload. So furosemide is used. If it does not give inadequate response, then we use IV nitroglycerin. If no response, then BNP analogs are given. So that's why I mentioned it in treatment of CHF. Okay. And then dobutamine is the inotrope of choice in heart failure, except in CHF with oliguria, wherein it's dopamine. Now again, dopamine, dobutamine, I have not explained here or discussed here. I request you to go back and read after the session. Chronic में what happens is cardiac output gradually decreases. So what happens is body activates compensatory mechanism. So if they succeed, then we call it as compensated. So basically, it's more or less normal. But if it's not adequate, then it's decompensated. So what happens is acute CHF plus decompensated chronic CHF, which is called as AHFS, which is acute heart failure syndrome, which will उसमें क्या होता है कि there is increased release of catecholamines, which stimulates beta 1, alpha 1, and RAS. That's why cardiac remodeling takes place. So increased oxygen demand, decreased oxygen supply, and that's whatever spoke in angina, and that's why mortality. So how do we treat? So the goal of treatment is to decrease the mortality and to block cardiac remodeling by blocking catecholamine action. So we use beta blockers to decrease contraction and ivabradine to decrease heart rate. This is about the heart. About the blood, we use isosorbide dinitrate and or hydralazine or a combination of both, and we use RAS blockers like ACE inhibitors, ARBs, spironolactone, etc. And if it's symptomatic, use digoxin. However, digoxin will just work on the symptoms. It will not reduce mortality. Whatever I said earlier will reduce mortality. With this, I hand over to Shraddha ma'am. Uh, I'm done with heart failure
Forest.
pharmacology.
So basically, all of you, when you see a patient, when will you suspect a heart failure? So either it can be a right ventricular failure, or it can be a left ventricular failure, or it can be a biventricular failure. So any patient who is coming to you with cardiology symptoms like dyspnea on exertion, which is progressive in the NYHA grade, how Aditya presented, or any patient who is coming to you with orthopnea, which is stage 4 NYHA, and breathlessness in a immediate supine position, or PND. Always remember PND, if any patient is having paroxysmal nocturnal dyspnea, that is a very, very classical left ventricular failure symptom. PND is pure cardiac symptomatology, whereas your other causes of breath, other types of breathlessness like NYHA, different grades, or orthopnea can come because of cardiology, it can come because of respiratory medicine, or it can come because of huge ascites as well, which is compressing on the diaphragm and reducing the lung total capacity to during to inflate basically. But PND, if your patient is having that, takes you straightly to the left ventricular failure. Other than that, there are some. So breathlessness is a backward failure symptom of a cardiology because of the congestion in the alveoli, because the pressure in LV is more, LA more, PV more, and then the alveolar congestion is occurring. J receptors are getting stimulated, and then there is something called as a Herring-Brewer reflex and short snappy respirations. Now, there are few forward failure symptoms that patient can come to you, like fatigability because reduction in the cardiac output and peripheral perfusion of the organs, which is reduced, and muscles, and that is why fatigability can come up. Other than that, patient can get syncope as well, which is transient loss of consciousness secondary to cerebral hypoperfusion associated with a postural loss. So that can also patient come to you, especially the forward failure symptom and low blood pressure patient. And then there can be angina, which can patient come to us with. So basically, when you examine a patient of heart failure, you look at the vitals, you look at the pulse, which will be feeble, especially if it is an acute decompensated heart failure with a cardiogenic shock, which is secondary to a severe massive myocardial infarction, like how Urmica presented the first case. If it is an acute massive anterolateral MI and there is so much of hypokinesia that the cardia is not able to generate the cardiac output, patient will come with a cardiac shock. So that is also acute heart failure. So that patient, you will have a feeble pulse, a low BP, the cold, clammy extremities, and then patient will be symptomatic with fatigue, maybe syncope, depressed sensorium because of the reduction in the cerebral perfusion, and the back pressure, which is causing the edematous lung and crepitations on auscultation you are getting. And somewhere Urmika also mentioned there is LVS3, which tells us that left ventricle dysfunction during that 80% diastolic receiving phase, which is occurring, and there is a S3 third heart sound, which is produced. So all these things clinically you will get. But if it is a chronic onset, like the same patient, he survived somehow the acute episode of myocardial infarction, but slowly, because of LV remodeling, because of death of the myocyte, because of fibrosis, the patient has developed over a period of time a chronic heart failure. Dheere dheere hua. All this diabetic, hypertension, there are multiple causes of cardiomyopathy and heart failure: diabetes, obesity, hypertension, ischemia, coronary artery disease, smoking, many are the thyroid cardiomyopathies, postpartum cardiomyopathies, drug induced cardiomyopathies, and fibrosis. So there are multiple out of them. So basically, when it is a chronic heart failure, slowly the patient is going to present. Now Aditya's patient was alcoholic, it can be beriberi, it can be a wet beriberi because of thiamine deficiency, correct? So slowly the patient's symptoms of breathlessness will progress from in the NYHA grading. Palpitations may come up, syncope may come up, fatigability may come up, PND has come up into a patient, and then that is how it will present. So these patients may not present with a very low BP like 60-70 systolic BP. Now if you see Aditya's case, then it is a normal blood pressure that patient was having. So basically, when you suspect, now you know when to suspect a heart failure. And when you look at examination, you will get all the right ventricular, left ventricular signs, symptoms है हमारे. तो signs में क्या मिलेगा हमें? So left ventricular forward failure, your pulse will be feeble, BP will be low. Backward failure, left ventricle, you auscultate over the chest and you are going to get crepitations, correct, of pulmonary edema. Now, the right ventricular signs which you are going to get is the JVP is going to be elevated. Pedal edema because of increased systemic venous hypertension issue. And then you will get something called as a congested, painful liver, as soft as the lips, but it is painful because of the tricuspid regurgitation and congestion. You may get some ascites also because of the increased hydrostatic pressure which is there because of increased systemic venous hypertension. So basically these are the signs that you are going to get in your right, left or biventricular failure. Now what are you going to do from investigation point of view? So basically I want to prove the heart failure, I'll have to do a 2D ecography. So when you do a 2D ecography, you look up what is something called as a ejection fraction. So what is that LVEF, ejection fraction, which will be normally around 55-60%. So in our case it was 30%. So then you classify heart failure into two groups: heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. What Pauras was saying was a forward failure, backward failure jo tha. So basically systolic or diastolic dysfunction. So heart failure with preserved ejection fraction is something just more of a diastolic dysfunction while accepting in the diastolic period, and forward the stroke volume is whatever the LV and diastolic volume is there, it is pumping it out. Whereas heart failure with reduced ejection fraction, which Aditya's case had, so that is something, the ejection fraction itself is a 30%. It is not able to, LV is not able to generate that much pressure to put that cardiac output or to generate that cardiac output. So does the line of management changes? Yes, little bit it changes. So listen to me very carefully. When it is a heart failure with reduced ejection fraction, according to AHA guidelines, you can give ARNIs, that is angiotensin receptor neprilysin inhibitors. Okay, that's sacubitril valsartan. Preserved ejection fraction, there is not much of a role of ARNI. And then other than the diuretics which Pauras said, the RAS blockage which he said, and the beta blocker you should not give when there is acute decompensated heart failure, when your patients are having crepitations because of the contractility inotropism which will be reduced and it will worsen. So do auscultate by a stethoscope every day before writing a for a beta blocker. And then there is one more group of drugs, MRAs you can give, mineralocorticoid receptor antagonists like spironolactone, eplerenone, wonderful drugs for heart failure. And after that, there is one drug which is SGLT2 inhibitors, Nishit. So SGLT2 inhibitors, आपको किसी भी heart failure, whether the patient is diabetic or patient is not diabetic, still you can give, okay? So heart failure without diabetes also, because what kya hone wala? Is it going to cause hypoglycemia? Suppose my sugar is 120, while taking SGLT2 inhibitor, will I get hypoglycemia? Never, because मेरा renal threshold जो है वो कभी cross ही नहीं होगा. And that is why the sugar is never going to get thrown away out of the nephron. Are you understanding this? And that is why SGLT2 inhibitor will not cause hypoglycemia unless you have crossed the renal threshold, Aditi. And that is one group of drug which you can use in both HEPREF and HEPF. That is, HEPREF is reduced and HEPF is preserved ejection fraction. And then after that, Samriddhi, there is one more, always one golden rule for all of you from me is anemia. Always rule out anemia whenever your patient is presenting with cardiology symptoms. Anemia can cause fatigue, it can cause breathlessness, it can sometimes cause angina as well. So basically, anemia, it can cause syncope as well. So basically, anemia is a great mimicker of cardiology symptoms, and anemia can precipitate a heart failure, because anything which causes anemia will cause tachycardia, diastolic period कम हो जाएगा, coronary का perfusion कम हो जाएगा, और फिर diastole में diastolic period कम हो जाएगा, plus whatever was coming from LA to LV, it has less time, LA ka congestion, PV ka congestion, pulmonary edema. That is how, okay, and more tachycardia, so again it worsens the heart failure. So always, whenever in general the dictum is, if the hemoglobin is below 7, you generally transfuse by packed cell volume, okay. But for heart failure, all of you, Tanya, for heart failure up to 10, even if it is below between 7 to 10 margin also, there is a indication for transfusion under a Lasix cover, because patient should not go into the pulmonary edema under a furosemide cover. Or else you can give, there is a huge role, there is a very good role of injectable iron preparations in the form of iron sucrose, or you can give ferrium carboxymaltose. Amazing improvement patient gets. So basically, chronic heart failure, look up what is the cause. And one blood test which you can do is NT-proBNP level. So as Pauras said that कि ANP, BNP ये सब release हो जाते हैं. सो एक्चुअली क्लिनिकली हम हार्ट फेलियर डायग्नोज कर देते हैं, लेकिन बहुत सारे पेशेंट्स होते हैं जिसको आप नहीं कर पाते हो, यू आर नॉट श्योर अबाउट, मे बी इको इज नॉट अवेलेबल अर्ली and you are in emergency, you don't have that much time, and then sometimes you can send that NT-proBNP level. It has both diagnostic as well as therapeutic value also, so that you will see that it is reducing with your time. So blood investigation, NT-proBNP, imaging, 2D echo, something you can do. All right, ECG is something which you can do. And then management is you can give diuretics, which is Lasix or torsemide, or else you can give, plus you can give MRS, spironolactone, eplerenone. That is something which is favored. Look for the iron, correct the anemia, and then what you have to do is RAS blockage. If it is HEPREV, give ARNIS to a patient. Okay, give ARNIS to a patient. It is a wonderful drug, sacubitril valsartan. And then beta blockers, be very, very careful when it is acute decompensated heart failure with crepitations. And then acute हार्ट फेलियर अगर वर्निका का पेशेंट कार्डियोजेनिक शॉक में जाता था, तो what उर्मिका का, so what we would have done is, then there is, you cannot give all the RAS blockage, beta blockage, because that is going to cause hypertension to a patient, correct? तो already hypertension में है तो आप कैसे दोगे फिर? So that is a time when you have to give all these inotropic supports like noradrenaline, dopamine, dopamine comes into picture at that point of time. Okay. Plus there is something called as, now let me tell you a concept of IABP. Okay, Nishit. So there is something called as intra-aortic balloon counterpulsations. This is a invasive modality for a cardiogenic shock secondary to suppose a acute MI. So what we do here is, in this, there is an intra-aortic balloon which is kept in somewhere in the descending thoracic aorta. So you go via a femoral artery approach and you enter into the femoral artery. You go upwards, Aditya, and then you reach at the level of the aorta, thoracic aorta. And there is a balloon which is there with that catheter with which you have, like from femoral artery with which you have come with. So basically, you will inflate that balloon intra-aortically. So intra-aortic balloon. Now you are going to give a counterpulsation. So basically, what you do here is you inflate that balloon during the diastole only. Okay, and how it helps. And during systole, you deflate that balloon. So when the left ventricle is pumping during the systole and the stroke volume is coming out of the left ventricle, it is going from the ascending aorta, arch of aorta, descending aorta, thoracic aorta, downwards to the abdominal aorta and everywhere in other organs, because during the systole the balloon is deflated. It is not causing any obstruction for the forward passage of blood during the systole. But the same balloon you inflate during the diastole. And why do you inflate during the diastole? Is because as you inflate the balloon during diastole, there will be obstruction for the forward passage of the blood from the root of the aorta downwards ahead of the balloon. Agreed? And because of which there will be some pooling of the blood prior to balloon, with some pressure will occur. And your problem with ischemic cardiomyopathy, ACS, is what? Your coronaries are not getting filled properly, correct? And that is why your coronaries get filled during which period of the cardiac cycle? Diastole. And hence, as you have obstructed the forward flow of the blood in the diastole by inflating that balloon somewhere in the thoracic aorta, you help for the feeling of the coronaries with that stagnant blood and pressure, with increased pressure. And that is how the coronaries get filled, and that is how there is going to be a good perfusion of the myocardium and good contractility of the myocardium. Okay, so that is the concept of IABP, which we use for 2 to 3 days till the cardiogenic shock because of ischemic MI is something which is there. Now coming to the surgical management of heart failure. So there is something called as heart transplant. So we know, I have seen only one till now in one of my colleagues' father for a heart failure. But there is something called as LVADs. So LVADs are left ventricular assist devices. So heart failure में क्या हो रहा है ना? The left ventricle is not able to pump it out and put it into the ascending aorta with that much of pressure, correct? So this LV assist devices, LVADs it is called, is expensive, way expensive, 25 lakhs and all it is going to cost, and way heavy. So basically, these LVADs are something which are going to, whatever the left ventricle was doing the function, they are going to pump it out. So just remember, as of now, there are something called as a surgical management of heart failure in the form of LVADs and heart transplant. And acute heart decompensated heart failure, read about IABP. It is superb. Okay. So that is about the heart failure that I wanted to tell from the clinical point of view to all of you. That's it. And then we will move to the last topic for the day by Aditi Gaikwad. A short one. We will not take more than 20 minutes. So stay with us. Aditi, start presenting.
Yes, am I audible, ma'am?
Yes.
So, good evening, everyone. Today I'll be presenting about arrhythmias. So, the patient is a 75-year-old male who's a resident of Nalasopara. He's a reformed smoker and works for a daily wage. He has 3 children and a deceased wife. He presents to the EMS with chief complaints of breathlessness, palpitations, and cough. Palpitations were of sudden onset since 2 days and were intermittent, irregular, and not associated with loss of consciousness. He has breathlessness on exertion, which is of grade 2 and is insidious in onset and progressive in nature. It has turned up to grade 4 since the past 2 days, and the patient has orthopnea. He has cough with expectoration since 2 days. It is whitish, mucoid in nature with no blood streaks. Bilateral lower limb swelling is seen, which is insidious in onset, progressive in nature, and extent is till the ankle. It increases in the evening. He complains of right sided chest pain, which is on and off since 2 days. There is no history of diabetes, hypertension, or valvular heart disease. He has asthma and he has a history of smoking for the past 50 years. There were no similar palpitation episodes in the past. There is no significant family history. Now, the examination. General examination shows a pulse of 130 beats per minute, which is irregularly irregular, a blood pressure of 130 over 80 millimeters of mercury. His JVP is increased with an absent A wave, and the O2 saturation is 95%. No pallor, edema, cyanosis, icterus clubbing, or lymphadenopathy was found. Pedal edema is present. CVS examination shows that the first and second heart sounds are normal and no murmurs are there. The examination of the respiratory system shows bilateral basal crepitations on auscultation. The investigations were done were the investigations that were done was an ECG with a V rate of 121 to 200 beats per meter with irregular atrial activity, leading us to think that it could be atrial fibrillation. A 2D echocardiogram was done, which showed a non-valvular atrial fibrillation. An HRCT of the chest was done, which showed centrilobular and paraseptal emphysematous changes in both lungs. Areas of ground glass opacity forming consolidation in the anterior segment of the left upper lobe and lingula were suggestive of infective etiology. The further advised investigations were thyroid function tests and serum electrolytes. So the final diagnosis was made of a non-valvular atrial fibrillation, and the patient was hemodynamically stable. The medication prescribed was intravenous injection of Lasix furosemide, which is a loop diuretic, an intravenous injection of Met XL, which is metoprolol, a beta blocker, and Dilzim sustained release tablets, which is an anti-anginal. Now, asthma medication was continued through the acetylene respirator solution, and his Chadsworth score was of 2 points since his age is 75 years. Now, for this, anticoagulants were prescribed, which included a subcutaneous injection of heparin and tablet dabigatran. So, my questions to the audience would just be what would be the course of action if the patient was hemodynamically unstable, and what is the surgical management of atrial fibrillation? So, with this, I'd like
Anyone want
to,
the questions?
yeah.
Anybody? Very good, Aditi. Anybody want to answer? Nishit, do you know the answers? This patient came with atrial fibrillation, but BP was normal. But what if the BP would have been low? What would I have done? Would you have stick to the medical management of rate control, or you would have done something else? And second is anybody final year surgical management of atrial fibrillation. Anybody has read about the Coxsmith procedure, pulmonary vein ablation? All right. For us, quickly in next 5 minutes or so, just present. Try to present quickly.
Quickly. I guess the PPT is visible.
Yes.
So we'll we'll talk about antiarrhythmics specifically here. So, like you should be knowing the electrophysiology for it, but I won't go into deep details of it. However, you very well know that there are four phases to the ventricle. This is a action potential graph for the ventricular action or the myocardial ventricular action potential. So there are four phases, so five phases: zero, 1, 2, 3, 4, in which there is a sudden depolarization, uh, early repolarization, a plateau phase, late repolarization, uh, and stage four, which is yeah. So we have accordingly we have four classes of drugs acting on the various, like we know, like in the action potential, sodium, potassium, calcium are the ions which are involved, right? So and we have drugs acting on those channels, as well as we have drugs directly acting on the heart as well. So we have the Vaughan Williams classification for the classification of antiarrhythmic drugs. What I'm showing you here is the modernized version of it, in which there is class 0 as well, which is the HCN channel blocker, which inhibits the funny current, and the drug is ivabradine. Then we have class 1 drugs. So I'll explain how you can remember with the help of this diagram. So just remember, like example, this is the cell, and outside the cell we have sodium. On the first slide, it was written sodium is greater in the ECF. On the cell membrane, we have the beta receptors. Inside the cell, potassium, intracellular potassium level is high, so potassium. And in the sarcoplasmic reticulum, we have calcium. So just go from outside to inside. So sodium, the class 1 drugs is sodium channel blocker, which are membrane stabilizing agents. So they are again A, B, C. So 1A is moderately depressing phase 0 depolarization, like quinidine, procainamide, and disopyramide. 1B is minimum or very weak effect, in which you have lignocaine and mexilatin. In 1C, we have markedly, like very strong depressors of phase 0 depolarization, which is flecainide and propafenone. Then we have on the cell membrane, you can imagine beta receptors. So we have gone little inside, like we were in ECF. Now on the cell membrane is beta. So class 2 will be beta blockers, like propranolol, atenolol, esmolol, metoprolol, sotalol. Then go more inside, that is in the cell, in the ICF, there is potassium. So class 3 is potassium channel blockers, which will prolong the duration of action potential. The examples are amiodarone, dronedarone, sotalol, dofetilide, ibutylide, and bretylium. Now you must have seen that sotalol is here as well and here as well. So yeah, sotalol is both class 2 and class 3. Then go more inside, which is in an organelle, which is sarcoplasmic reticulum. So in that we have calcium. So class 4 is calcium channel blocker, which is verapamil and diltiazem. And class 5 is miscellaneous drugs like digoxin, adenosine, atropine, and magnesium sulfate, of which I won't be speaking about digoxin and atropine in great details because I've spoken about it earlier. So let's go. Class 0 is ivabradine, which acts by delaying the depolarization by blocking the sodium channels. Sorry, just a minute. Yeah, yeah. So yeah, it blocks the AC node and decreases heart rate, which causes bradycardia. Indications are stable angina and chronic CHF. Uh, then class 1 may you have class 1A, 1B, 1C. So various uh, comparison is given, in which I'll just focus on a few. In this one, 1A acts on sodium channel in open state, Same with 1C, but however, 1B acts on the closed state. 1A is significant potassium channel blocker, so it will increase the QT interval. However, 1B is potassium channel opener, so it will decrease QT interval. However, 1C is negligible potassium channel blocker, or not even an opener, so it is more or less the same. Then, as I said, QT prolongation, and QT shortening, and no effect. Then increased refractoriness in normal cells and accessory pathway is there in 1A. And Baki ka you can read later on. I will give the PPT to you all as well. So class 1 may we have this many drugs. So quinidine, procainamide and disopyramide are 1A. Lignocaine and mexiletine is 1B, and flecainide and propafenone is 1C. Therapeutic uses of quinidine are many, but it's not drug of choice in anything. Procainamide is used in ventricular arrhythmias associated with myocardial infarction. Disopyramide is used again in ventricular arrhythmias treatment or to maintain sinus rhythm in atrial fibrillation or flutter. Not treatment, but just to maintain. Okay. Lignocaine and mexiletine is IV used in emergency treatment of ventricular arrhythmias associated with MI. Is the drug of choice in digitalis toxicity and associated with MI, digitalis toxicity and cardiac surgery. And flecainide is treatment in SVT. And yeah, can also be used in ventricular arrhythmias. ADRs are simple like diarrhea, hypotension, thrombocytopenia. In some of them, you have torsades and mental confusion, etc. Disopyramids, you have BPH or precipitation of acute attack of glaucoma. I'm just focusing on the special ones. In flecainide, the important one is exacerbation of arrhythmias. Like it is a paradox, I would say. And metallic taste, constipation, or yeah, bronchospasms or blurring of vision. Class 2, remember, is beta blockers. I've explained beta blockers in great detail in hypertension, so I won't repeat. But in arrhythmia, what it does is depresses phase 4 depolarization, thus decrease automaticity in SA node and ectopic foci. Like which, if the pathophysiology is increased by adrenergic stimulation, and thus also it prolongs refractory period and decrease the conduction in velocity in the AV node. Class 3 is potassium channel blockers like amiodarone. We'll discuss amiodarone here. So it blocks potassium channels, thus increases duration of action potential, prolongs refractory period, and thus suppresses abnormal atomicity. Amiodarone, it also blocks sodium channels well in the inactivated state, thus decreases conduction mainly in the partially depolarized tissue. So, blockade of sodium potassium as a whole channels ch- uh, sorry channels prolongs refractory period in the cardiac tissue. It also has weak beta blocking activity and CCB actions like calcium channel blocker actions. Indications again wide uses. It's used in many arrhythmias, but it is the drug of choice for rhythm control in atrial fibrillation or atrial flutter, in ventricular tachycardia and ventricular fibrillation. Adverse drug reactions in this one are very important, like pulmonary fibrosis, vortex keratopathy, ceruloderma, which is blue, like darkening or the pigmentation of skin, myocarditis, levogranulomas, hypotension, and photosensitivity and thyrotoxicity. Now, all, like in case of amiodarone, like all these drug reactions are very important. Like I won't say one is less important. Like I have said earlier. Class 4 is again calcium channel blockers. So it blocks both activated and inactivated L-type calcium channels, thus depresses calcium mediated depolarization. I have talked about calcium channel blockers earlier. Lastly, class 5, there's miscellaneous. First, we'll talk about the adenosine. So what happens when you give intravenous adenosine? It binds to specific protein coupled adenosine receptors, which activates acetylcholine sensitive potassium channels in atrium, SA and SV nodes. Thus, there is potassium efflux causing hyperpolarization and decreased automaticity of SA node, thus decreased sinus rate. Also reduces duration of action potential in atria and reduced excitability and increased refractory period and slowing of conduction in AV node. It also decreases calcium currents in AV node, thus depresses the AV node. So the uses is it is a drug of choice for acute attack of supraventricular tachycardia or paroxysmal supraventricular tachycardia. It is also used to maintain controlled hypertension during surgery or for diagnosis of CAD. Adverse drug reactions are asystole, bronchospasm, chest pain, dyspnea. Sorry, that is typo. Uh, Flushing, hypotension, and headache. It is not used in atrial fibrillation. Remember, because it itself may, it is a risk. It may cause increased risk for atrial fibrillation. Remember, and the contraindications are COPD, asthma, and transplanted heart because there's denervation. So it's you can't basically use it. Then lastly, magnesium sulfate. It's an important drug. It blocks calcium channel and leads to early repolarization. And it's the drug of choice for torsades. Okay, like long QT syndrome may like the uh, if it presents acutely, it's called torsades. So you can read more on that. It's out of scope of this talk, I would say. And lastly, atropine. Again, I won't talk in detail about it because it's from autonomic nervous system pharmacology. However, in short, it's an anticholinergic, so it increases heart rate and AV conduction. So it's the drug of choice for bradyarrhythmias and for AV block. Bradyarrhythmias could be like sinus arrest, sinus bradycardia, or inferior wall MI associated bradyarrhythmia. So, like in this case, like for example, what we discussed, the case of atrial fibrillation, to the treatment of atrial fibrillation and atrial flutter, we'll discuss. In case of an acute attack of AFib, the treatment of choice is cardioversion. Don't call it a drug of choice. Okay, it's a treatment of choice is cardioversion. However, if you want to at all give a drug, the drug of choice is IV ibutilide. Okay, the long-term management is there are two aspects of it. One is rate control and one is rhythm control. So, what are the goals of rate control? Is to keep the ventricular rate less than 100 beats per minute. So, the drug of choice is beta blockers. For the rhythm control, what how what happens in AFib is there is non-sinus rhythm caused by functional circuit created in the atrium which generates action potential. Okay, so the drug of choice in this is amiodarone, which like we discussed just a while ago. And lastly, treatment of supraventricular tachycardia or paroxysmal supraventricular tachycardia. For the prophylaxis, we have preferred beta blockers. The next choice is verapamil, uh, which is a calcium channel blocker, and next choice is digoxin. For an acute attack, the drug of choice is IV adenosine. Basically, short-acting drugs are preferred. With this, I end my part. I'll end with a quote that by Les Brown that you must tell yourself, no matter how hard it is or how hard it gets, I'm going to make it. And just keep on hustling, just keep on grinding for it, and these small efforts will contribute to a big success, big impact. Thank you so much. My contact details are here, and I hand over to Shraddha ma'am. Thank you.
Wonderful, wonderful, wonderful. All of you, please put your video modes on. So, arrhythmia is something. No, it is one of the most difficult topic, and every medical student, when in second year, they or in final year, or during their residency, also as a MD, they find it is so difficult. So, you need to invest time to understand arrhythmias, and teaching in our period also is going to be difficult for us. But you have really justified the topic by the type of efforts that you have put in for us for that classification is really really outstanding. very well presented, Aditi as well, all of you. So basically, I do not have much to say after what Porus has presented. But basically, when a patient of any arrhythmia comes to you, check the electrolytes, because electrolyte imbalance can cause arrhythmias like calcium, magnesium, sodium, potassium, and then ischemia can cause arrhythmia, or any basically any congenital arrhythmias are also there. So basically you look up if it is any arrhythmia, whether it is ventricular, supraventricular, whether it is hemodynamically stable or it is hemodynamically unstable. So any arrhythmia, be it svt, be it vt, if it is hemodynamically unstable, as Pora said, you have to do something called as a cardioversion urgently. So there is electrical cardioversion, where you give the DC shock, and for supraventricular, you give a lesser joules like 50, 100, and for ventricular, you start with 200, 250, and go up to 300 and all. And there is chemical cardioversion is also there. So basically, you want to, whatever arrhythmia is there, you want to convert it into the sinus rhythm. That is what is the logic of doing the cardioversion. Okay. And why there is hypotension? Because there will not be any adequate left ventricular end diastolic volume, and left ventricular contraction will not occur, because all the beats will not come down and stimulate the left ventricle. If it is supraventricular tachycardia or something, there can be a variable block. And then especially because this case was a atrial fibrillation case, so there is something called as a rhythm control versus rate control. Atrial fibrillation, generally rhythm control is very, very difficult. It is difficult to go back to the normal sinus rhythm because of the scarred left atrium. And that is why, to achieve the hemodynamic stability, at least we do a rate control. And you can do the rate control by A, B, C, D. That is how I remember: A for amiodarone, B for beta glucan, C for non-dihydropyridine calcium channel blocker, D for digoxin, or that is what you can use. And if you really want to do a rhythm control, then cardioversion ibutilide is something which you can do. But before giving a DC cardioversion, or before giving a chemical cardioversion with ibutilide also, you should make sure that there is no left atrial clot in the atrial appendage or LA, because आप जब cardioversion करोगे ना, as soon as the sinus rhythm is achieved, it is possible that this left atrial clot will just go to LV, and it can cause a focal neurological deficit and a stroke to a patient. So what to do? So you do a echo, either a transthoracic or transesophageal echo, and you make sure that there is no clot. If there is a clot, then what to do? If it is emergency, you give anticoagulation and then do the cardioversion. But if it is a planned cardioversion, then at least it is recommended that 3 weeks of anticoagulation you should do to a patient with heparin and other anticoagulants. Now, this patient, Aditi also calculated one score. So whenever you see AFib, no, you have to find out whether it is a valvular AFib because of MSMR, that type of valve problem, because of rheumatic heart disease or any other valve problems, or if it is a non-valvular. So valve endocardium is something which is a bang on normal, but it is a muscle problem and myocardium problem, and that is why the AFib has come. Like hyperthyroidism can cause AFib, hypothyroidism can cause AFib. So basically, it is a valvular or non-valvular AFib. And when it is non-valvular AFib, we calculate that CHADVAS score. So that CHADVAS to score, the components of that is the congestive heart failure, hypertension, diabetes, age more than 75 has 2 points, less than 65 to 75 has 1 point, the female sex gets 1 point. So basically, there are multiple parameters. And as you calculate the CHADVAS score, if the score is 2 or more than 2, then there is an indication to give extra added anticoagulation like heparin and vitamin K antagonists like warfarin, or there is you can give novel oral anticoagulant agents like dabigatran, rivaroxaban, apixaban. So basically, you have to give that. Why you are giving it? Because atrial fibrillation में क्या हो रहा है ना? It is atria is not contracting. It is just fibrillating like this. And because of this, you now go back and think about the Virchow's triad, so which causes hypercoagulability. So it is the endothelial integrity damage, it is the stasis, and it is the hypercoagulability. And because of this atrial fibrillation, which is now like this, so stasis की वजह से क्लॉट फॉर्म हो जाता है, और उसके वजह से दैट इज वाई कार्डियोम्बोलिक स्ट्रोक हो सकता है, और इसीलिए यू हैव टू गिव द एंटीकोagulation. ठीक है. But then there is one more score which is called as a Hasbled score, HASBLEED. So Hasbled score tells you that after you start anticoagulation to a patient of atrial fibrillation, what is his probability to get bleeding complications because of that anticoagulation which you have started. So generally, these two scores are extremely important from clinical point of view. And as I said that you send electrolytes, especially for AFib, TSH, T3, T4 is extremely important, and get an echo to look up for if it is cardiac or it is valvular or it is non-valvular AFib. And overall for any arrhythmia with hemodynamic instability, urgent cardioversion is something which is required to achieve that hemodynamic stability. Otherwise, if patient is hemodynamically stable, then you can just do either a rate control or you can do a rhythm control. So basically, that is what, if your last line, I will say that if you're confused about any arrhythmia, I tell my students that amiodaron is something which is the safest. If you're not able to find out whether it's SVT, VT, kya hai, give amiodaron 150 to 300 milligram over 10 minutes, and that is something which you can play a safe game. And because it has a multiple level of actions, that is why. And uh, carotid massage is something which I want you to tell you, in SVTs especially. So you give a unilateral, never bilateral. This is extremely important. So give a unilateral carotid massage, and that is something which is reduces, it reduces the AV conduction, and that reduces the ventricular rate. So carotid massage is something with the thumb at the anterior border of the sternocleidomastoid near the cricoid cartilage at the C6 level. You can just give the compression in a circular manner. So that is something which is just before pushing the adenosine. One more thing about adenosine is very wonderful is adenosine is very expensive drug. So 12 milligram of adenosine cost around some 600 rupees. That is expensive for any particular patient who is coming to KM. And that is why basically adenosine has a very short half life. So if you give adenosine through a when you have to give adenosine intravenously, now you literally have to give through a major vein. So you have to either give through the internal jugular or external jugular, or you really have to give a good quick shot of adenosine. Okay, you cannot give through a vein which is somewhere over here, dorsum of the hand. जब तक वो हार्ट तक पहुंच जाएगा ना, उसका हाफ लाइफ खत्म हो जाता है. So either a brachial is something which we choose for giving adenosine, or internal jugular डालने में तो टाइम लगेगा ना, सेंट्रल लाइन डालने में, या फिर एक्सटर्नल जुगुलर भी आप डाल सकते हो. So that is something you give adenosine. And 12 6 6 something like 6 12 6 something like that, we repeat the doses of adenosine. Bronchial asthma is one of a very important contraindication for giving adenosine. So arrhythmia is something which is a very difficult topic, and you really have to understand the pathophysiology and the physiology first, and then only you will understand the pathology in arrhythmia. So you really need to give your like days to understand arrhythmias. Okay, so that's it from our side for today. And thank you all for joining us. And rest all faculties who have presented, please put your video modes on so that Aditya Nair kidhar hai? Aditya Nair ko bulao jaldi se, so that we can take a snapshot. Aditya Nair has come. Thank you, Porus. You had put lots and lots of efforts, lots and lots of efforts. Really
Thank you so much,
appreciate
Radhi.
that. Appreciate that. And Aditi, Urmika, Archit, Aditya, you have set a benchmark today. Nobody has done this for us, correct? In your
Yeah.
entire batch, put your video modes on, all of you. And nobody has done this till now in your entire batch. And what you people have done today is really outstanding. Really outstanding. It was so difficult. It is very difficult to present something which you have not learned or you have not understood. Okay, so that is very difficult, because that presentation में बहुत difficulty हो जाती है. So see,
I
I can,
really appreciate, even I
yeah,
appreciate like how well they
the
have done.
confidence,
Means
guys, the
like
confidence is something which is
means I
really.
see like I didn't even know what is like drugs is
Even when
definitely
I
one
was in
thing,
my
but
second year,
clinical like when I began, I did not know what is NYJ grading and
absolutely,
like Chad's vast score and like, but
absolutely,
yes, it was
absolutely.
wonderful to.
When I was in second year, I was not even 10% of what you guys are. So long way to go for all of you, and really good efforts, good presentation.